Hello, I'm Manoj Karmakar. I'm your host, and I'm the convener of the ISSPS 2021. I welcome you to this event. Wherever you are, I hope you are safe and healthy. For those of you who are returning to this third webinar, welcome back. Obviously, I bring you greetings from this beautiful city of Hong Kong. We are coming to you live from the studios at the Prince of Wales Hospital. It's part of the Chinese University of Hong Kong. And we hope you'll visit us soon one of these days. This event is being organized by the Department of Anesthesia and Intensive Care and is part of the 40th anniversary celebration of the Faculty of Medicine of the Chinese University. It is also the 10th event, the 10th edition of the ISSPS. We started way back in 2009. We're supported by a host of different companies and equipment providers. I'm most grateful to them, without whose support, it would be difficult to bring this event to you. I'm proud to announce that today we have about 2,855 participants registered from around the world for this webinar series. This is a distribution of participants from different countries and continents. The maximum is from the Asia Pacific region, including Australia and New Zealand. We're also pleased to see 65 participants from way back far away in Bolivia, Peru, Argentina, Brazil, and I welcome you all to this event. To top the notch and top place is participation from India with 561 and from China about 380. So today, after having discussed the basics of spine and paravertebral sonography and its applications for anesthesia and pain medicine, today we are going to up the ante a little bit, and we'll be discussing some more complex issues pertaining to the applications of neuraxial blocks in obese, the Parturient, and patients with difficult spine. And to do so, I'm joined by three great teachers from different continents and I'm really pleased that they are with us today. I understand it's very late in the night for some, it's very early in the morning for some, and I really appreciate your contribution and your participation. For all of you, you already know Dr. Kenneth Sheah, his wonderful presentations in the last 2 webinars, and I hope, as you do, to expect nothing less than what he did in the first 2 webinars. He's a diagnostic radiologist who has a very keen interest in pain medicine from Singapore, and I need not say more because you've seen his contributions. Coming all the way from Philadelphia is a good friend of mine, Associate Professor Jaime Baratta. She comes from the Thomas Jefferson University, which is part of the Sidney Kimmel Medical College in Philadelphia. She's also the Director of Regional Anesthesia and Acute Pain Medicine at this university hospital, and the Director of the residency program in that institution. She's going to share with us her experience and a know-how about how we can use ultrasound for spinal sonography and interventions in the obese individuals. Now, coming all the way, a champion from Palo Alto, from the Stanford University, is Professor Brendan Carvalho. He's one of the biggest names in the field of obstetric anesthesia. He's the chief of the Division of Obstetric Anesthesia at Stanford University. He's also the ex-president of the Society of Obstetric Anesthesia and Perinatology. And today he will be sharing with us his experience on the use of ultrasound in the obese Parturient. In the Parturient. Okay, before I get the program going, a couple of housekeeping matters, because, for instance, Professor Carvalho is joining us from Palo Alto in California. It's 2 a.m. in the morning. I wouldn't want to keep him, hold him for the Q&A, so I will be the person taking the Q&As on behalf of him. So unfortunately, he will leave us, and I hope you'll understand that. The format is in the form of a webinar, so you as an attendee have limited privileges, but you can ask questions. The questions will be in the form of Q&A at the end of the first 3 lectures, so that if any of the speakers would like to leave because of inconvenience, they are most welcome to. So please put your questions through the chat section, and one of our moderators, Dr. Rossini Wong, will pick them up and present it to the speakers during the Q&A session after the 3rd lecture by Dr. Sheah. Do mention from where you are from after the question. Finally, these are some books that you may find very useful. These are edited by us, including Dr. Sheah, who has also contributed in the Atlas of Sono Anatomy, the only correlative sono anatomy book in the field of regional anesthesia and pain medicine currently available. Next week, I hope you will join us again. We will be moving up a notch again to the cervical region, the sacral region, and we'll have 4 other experts from around the world join us. So without further ado, I'd like to welcome Dr. Baratta to make her presentation. Jaime?
So thank you everyone for having me. As Manoj, Dr. Karmakar mentioned, I'm from Philadelphia, Pennsylvania in the US, and I'm at Thomas Jefferson University. And I'll be speaking specifically on patients, the morbidly obese patient. So I have no disclosures relative to this talk. And the objectives, really what we're going to talk about is looking for pattern of recognition in the relevant sono anatomy in the obese patient, and talk about the benefits of spinal ultrasound specifically in the obese patient, as well as some of the challenges of spinal ultrasound in the obese patient. So just to show kind of where I'm from, again, you could see here that I'm from Philadelphia, Pennsylvania, not too far from New York City. So it's quite nice and early here, but not quite as early as it is in California. And these are some pictures of, where I work. It's a city hospital, it's an academic hospital, level 1 trauma center, and a very busy orthopedic and obstetric population as well. So what about obesity? The overall global prevalence of obesity has increased significantly over the past 40 years. It was really like less than 1% in the 70s, and now it's grown, to about 10% in men to 15% in women globally. Now, of course, the prevalence is greatest in the United States, but overall, there's a trend, as you can see here, all across the world. And in fact, while obesity was once associated mostly with high-income countries, the World Health Organization has found obesity increases in low and middle-income countries as well. And obese patients are frequently presenting for surgery and with comorbidities such as obstructive sleep apnea, cardiac disease, challenging. Hello? Challenging airway anatomy, and general anesthesia may not be the best option. So, in fact, close to half of the patients presenting for joint replacement surgery are obese, as are many of the parturients that present for surgery. So, and here again, showing, the US, we are leading, unfortunately, in obesity. And you can see here, as far as where I'm at, we're the second highest when it comes to obesity. So overall, obesity results in increased risk of technical difficulty when you're doing, especially neuraxial blocks or really any regional anesthesia on the spine. So with patients with higher BMI, they have poor back flexion, so they can't position as well as you can't palpate the bony landmarks, including the intercrystalline, the midline, the interlaminar space. And in an older study, they found that with landmark technique, obese patients had a failure rate of about 40%. And the majority of obese patients required more than one attempt, which can be, traumatic and for the patient as well as the provider doing the neuraxial technique. So in terms of palpation, there was a study in the obstetric patients where they looked at the vertebral level and found that it was correctly identified by palpation in only 55% of patients when compared to ultrasound. And in most cases, the presumed level identified by palpation was at least one level higher than the anesthesiologist thought, thus potentially setting up the patients for neurological complications. So if we're only identifying the correct space via palpation in the non-obese patient only half of the time, the likelihood of being accurate in the obese patient, where bony landmarks are rarely palpated, is very low. And there was a recent study of obese parturients with an average BMI over 40, and the authors compared landmark technique of just the transverse view and identifying midline to ultrasound. And they found that while identifying midline with ultrasound took approximately 15 seconds longer, the placement of the epidural was 2.5 minutes, faster, and the identification with the identification of midline. So they also found the number of needle passes was lower. Here was another study where they were comparing ultrasound to landmark technique. In non-obese and obese, but this was specifically going to look at the obese results. This was in parturients, and only the BMI was greater than 30 here, but they had a pre-puncture exam, so a pre-scan to identify the landmarks, and they found that the use of ultrasound, as you can see here, resulted in fewer puncture attempts, fewer levels attempted, less requiring of needle redirection. And overall, the spinal procedure time was lower, as you can see where the arrows are, as well. So, ultrasound was of significant benefit compared to just the landmark technique. So I skipped past the depth, and they found that this depth was about 1 centimeter, roughly deeper than what the ultrasound depth was. And here, what I'm talking about is, does the measured ultrasound depth match the actual needle depth? And how does that correlate? And a number of studies have examined this concept. And as seen here, the ultrasound and needle depth overall correlate well with the ultrasound depth obviously being less. So what you're going to measure on the ultrasound is going to be less, most likely because of tissue compression. So you have to account for that. And the literature varies as far as how much compression you might have to account for. It can be a 1 centimeter or even slightly more. So it's just important when you are trying to measure the depth to the dura or the posterior complex, and as far as your neuraxial structures, to note that the ultrasound depth is not going to be completely accurate. It will be likely a different depth. As you can see here in this another study, it's a very small study of morbidly obese parturients. Well, the ultrasound pre-procedure scanning took longer. The time of placement in this situation, the number of attempts, and the total procedure time were significantly less compared to the landmark technique. And while it wasn't significant, authors did note that the palpation group required replacement, bolus of catheter, and also had an unintentional dural puncture, which none of those complications occurred in the ultrasound group. Pre-procedural imaging of the obese patients presenting for orthopedic procedures also resulted in better first attempt success rate, as you can see here. And although while the spinal procedure time was lower in the ultrasound group compared to the landmark technique, you can see here that the total procedure time involving the pre-scanning was overall longer, but the benefit of fewer needle passes and better first-time success rate is likely beneficial. But is ultrasound of greater benefit in all obese patients? And here, when the authors compared ultrasound to landmark technique in, again, obese, this was an obese parturients, we can see they were able to, sorry about that, divide up based on BMI. So the lowest BMI 30 to less than 35 versus 35 to less than 40 to greater than 40. You can see in the lower group, there wasn't much difference in benefit as far as time to identify the structures and time taken for the spinal and total procedure time. But when you got into the higher BMI groups, there was a significant benefit. So maybe it's not that it's as beneficial for all obesity levels, but maybe the most severe obesity levels is where you're going to see the biggest difference in landmark technique. And ultrasound quality, unfortunately, when the structures are deeper, it's going to be harder to see. So this was just the abstract that we did, where you can see as the increase in body mass index, the ultrasound visibility is less. So in the obese population, it's going to be difficult to identify all the structures to differentiate between the ligamentum flavum, the posterior dura, the epidural space, as well as it's difficult to see the anterior complex and the vertebral body because it's much deeper structures. And it's all likely due to the increased attenuation as the ultrasound beam travels a greater distance. It's likely too that the attenuation is exaggerated simply because of just the irregularity of the adipose tissue, resulting in a lot of scattering of the ultrasound beam. And there's going to be a lot of reflection as well at the muscle adipose tissue interface. So not all of the ultrasound beam is going to be able to penetrate down to the structures. So all of this will degrade the image. So how I do it, it's important to remember all the different scans. And I know that was talked about in a previous talk. And I kind of change it up a little bit. I know a lot in general, most people will start with the paramedian or the sagittal views and identify the interspaces. In the obese patient, because I find I can easily get lost trying to identify the lamina because the structures can be difficult to see. I usually just kind of orient myself by finding midline, because I find that I can reliably find midline in all obese patients, while some of the other landmarks can be harder and take a little bit more time. So I try to orient myself by looking for the midline. So this would be, thinking about the transverse or the spinous process view. And just remember, with obese patients, you're going to have to adjust the depth, adjust the focus. You may need to turn the gain up. You're going to have to apply a lot of pressure with the probe. And then you're just going to look for the patterns that you're familiar with in the non-obese patients. Here, then we would move, so we look at for the spinous process and then look for the interspinous view. And at that point, I'm, marking the midline. And then I'll be looking at the paramedian sagittal oblique view and trying to find the lamina in the interspaces and identifying the different lumbar interspaces. So these images are from an older editorial, but I thought they were really nice images in an obese patient. I can see the structures very well. So this is a morbidly obese patient, was having an orthopedic procedure, and they actually were writing about how they tried to do the neuraxial technique with landmarks, and they had tried multiple times but were unsuccessful. And ultimately, they grabbed the ultrasound and they were able to identify the L3, L4 interspace via the parasagittal oblique view, which you can see there on the right side. And they were able to identify the midline by looking at the transverse interspinous view on the left-hand side. And they can even see, they point out the structures here on the left, the ligamentum flavum and the dura and the epidural space. So by getting the ultrasound out, they were able to easily get the successful intrathecal injection. So here are some scans just to show you the, what the images can look like in an obese patient. And of course, the dynamic images that you'll see when you're live ultrasounding are going to be, clear, and that's why practice is important. So here we have, looking at the transverse interspinous view in an obese parturient with a BMI of 44. And there we can see the shadow of the spinous process, and then, the hyperechoic lamina on the sides, and just all that drop out, because we're not going to see anything behind the spinous process. And then we move into interspinous view. So then we could see the shadow of the interspinous ligament. We can see the transverse processes out onto the side, a little bit of the articular process, and then we can start to see the posterior complex coming into view and the anterior complex, which you're not really always reliably going to see in obese patients, especially not the anterior complex, but you should be able to see some of the posterior complex in most patients from what I've found. And you could normally you could measure with calipers, but take note of about the depth of the structures. And then I move into the paramedian sagittal oblique, and we can see, looking at the sacrum on L5 and L4 and interspaces. And here you could actually see the epidural space here, so ligamentum flavum and the dura. And so we can see the epidural space nicely in there, and also catch the anterior complex here as well. So we can see pretty good structures in this obese patient and get valuable information. And we can see now I've scanned up to look at the different interspaces to mark them. So we can see now L5S1, L4, L5, and L3, L4. Of course, if you ever run into problems in the obese patient, the L5S1 is going to be the largest of the spaces. And we can still probably kind of see some area that might be, signifying the different structures of the posterior complex. But again, a lot of them are going to get fairly obstructed, and a lot of them you'll see better in just dynamic scanning. And so this was the patient from the previous scans. You can see we ended up marking and our interspaces, and we went at the location of the marks, and we actually got the epidural here at this, but we ended up getting some blood back, so we moved to the next level. So that's why it's important to do more than one level, because you never know when you're going to run into problems. And we can see we have a successful epidural placement in this obese patient. Here's just comparing some different views. I thought these views were interesting because we actually found in this case, looking at this transverse interspinous view, where the BMI of 62 patient actually had better spinal sonoanatomy than the lower BMI patient. So while usually the higher BMI will account for lower image quality, in general, you're going to see that, across, really as you get higher, the image quality is going to degrade compared to a non-obese patient. But a lot of times you'll be able to see some really great images in obese patients. So it's kind of somewhat unpredictable sometimes. So you can see the structures here in the transverse, interspinous view, the articular process here, the transverse process, and you can see this hyperechoic area, which would be your posterior complex, but those aren't as clear in these other images of the BMI 41 and 45. Here's just looking at some different views with non-obese patient versus an obese patient. So we can see clearly that the obese patient has less image quality, it's just not as crisp when looking at the transverse spinous view, where you can see the spinous process here and the lamina and the dropout. And again, it's just due to that degradation of the image due to the obesity in the adipose. Here, the same two patients looking at BMI, again, 25 and BMI 40 on the interspinous view. Here in the non-obese patient, we can clearly see our posterior complex here and our anterior complex here and our interspinous ligament. And here we'll see, we could see on the right, we could just see the interspinous ligament and probably see the posterior complex there at the arrow, but really can't see the anterior complex. And here are the same two patients, the paramedian sagittal oblique, and you could just again see that the images of the lamina and the interspaces and the posterior complex are much clearer than in the patient with a BMI of 40. You can still see, the horse's humps up there on the right in the lamina, but you can't see any part of the anterior complex in this image, just some of the hyperechoic posterior complex. So it still gives you good information. It can get you, where your interlaminar spaces. But you're not always going to see the structures you hope to see. And again, this is that first page, that BMI of 62, and this is the situation where this morbidly obese patient, super morbidly obese patient, has much better visualization in the paramedian sagittal oblique view than the BMI of 41. So in this situation, we could see the structures very well. Here is another patient. This was an orthopedic patient, was having a total joint replacement, and his BMI was 44, and he did not have any landmarks that could be palpated at all. So we decided to get the ultrasound out to scan. So first started looking for my spinous process and my midline, and I could see here, you can see the spinous process and there the lamina. So it's kind of the swan taking flight. That kind of gave me, we were able to mark midline, then moved in to look for the interspinous view into the inner space. And we could see the shadow of the interspinous ligament. You can see the articular process there. You can see that hyperechoic area that looks to be the posterior complex, and then to the lateral, we can see the transverse processes. You can see that horizontal line, which I marked as the posterior complex, around the 7.5 or so depth marker. And then I zoomed in a little bit, so it looks like it's at a different depth. But in my paramedian sagittal oblique, and I will say I turned up the gain on this view, so in the other views I definitely could have had that's a pitfall. I just wanted to really point out that remember to adjust your gain and adjust your focus while you're imaging the obese patient, because it can help optimize your images. So here, again, I'm looking at the interspaces I've actually scanned up from the sacrum to identify L3, L4 space, and we can see the lamina, the horse's heads, and the posterior complex there at about 7.5 centimeters. So as I like to say, it's scan first, pre-scan first, mark, and then success. In an obese patient, I don't feel there's any utility, especially for neuraxial, to do direct needle visualization under ultrasound for neuraxial. So it's really beneficial to do the pre-scan, mark, and then attempt the neuraxial technique. But it's really important to remember to be careful with the redirection, because if you kind of look at my graph, as here on the right, you can see the red line pointing, the horizontal line pointing at my target, which would be my neuraxial structures. But if you adjust your needle angle, just even the slightest, you're going to be significantly off your desired target. So it's important, you can't to try to estimate the angle which you're imaging when you're in that interspinous view, and it'll help kind of give you an idea of the angle of how you should place your needle. But just when you're doing neuraxial on the obese patient, just make sure you're very deliberate and careful with adjustments of your needle. So a small adjustment can go a long way in an obese patient just by the nature that the structures are so much deeper. And that's not the case in a non-obese patient. You can make a lot more adjustments and not have as much of an effect. It's also important that the skin in an obese patient can move. So it's really important to anchor the skin because it can kind of move around and you can get lost, especially off of your markings. So it's important to try to anchor with your 2 fingers is usually what I do to help kind of secure that space. This was a actually article where they talked a case report where they talked about a patient at a BMI of 50. This was again patient for orthopedic surgery. So here they have their transverse interspinous view, and you could see they measured all the way down to the posterior dura there, that hyperechoic white line. They can't really distinguish any of the structures there, but they measured, and that is 8.9 centimeters. So it's probably even deeper, with the or the tissue compression. So something to note that, and it can help you choose what length needle you might need in the obese patient, as opposed to struggling with a shorter needle and ultimately moving up to a longer needle. But you can see, you could still see quite a few of the structures, even in a patient with a BMI of 50. So again, it's really, really important to have pattern recognition. So this is a BMI of 41, again, a patient for orthopedic surgeon. So what view is this? It's kind of hard, again, better, see better in a dynamic view, but we could see that, our lamina are there, and we could see just a bit of that hyperechoic posterior dura. So this would be my paramedian sagittal oblique view, where I would identify some of the interspaces. So it takes practice. So practice on the non-obese, so that when you're faced with an obese patient, you can seamlessly do the ultrasound scans and have success. And I'll touch a little bit on thoracic epidural. Thoracic ultrasound has been shown to be useful to assist in the placement of thoracic epidural in obese patients, especially when landmarks are difficult to palpate. And in general, midline is fairly easy to identify with the transverse view, because even the transverse, the thoracic spine is not as deep as you'd expect in the lumbar spine. So I think the hardest area really is in the lumbar area, because those structures are so much deeper. So in general, midline is easily identified, but visualization of the interspace in the paramedian sagittal oblique can be a lot more difficult, just in general, because of the thoracic spine anatomy. But it's not impossible. There was a study where all morbidly obese patients with an average BMI of 45, they found the posterior complex was visualized in all patients via the sagittal view, and resulted in the majority receiving first attempt success with thoracic epidural placement. But it's important to note that they did not, that they did demonstrate a significant difference in actual needle depth versus ultrasound measured depth. So again, pay attention to the depth. It's not going to be the same when you're using ultrasound as opposed to needle depth, because of that tissue compression. So, here you could see the spinous process and the transverse process. Here's another thoracic image, and we can see here midline and the transverse process. So I've talked a lot about achieving the optimal image, for the obese patient, but it can be quite difficult, and serious complications can result, such as accidental dural puncture, epidural hematoma, spinal cord injury, and pneumothorax, especially when you're doing thoracic regional anesthesia. Specifically talking about paravertebrals. But these techniques are really valuable in the obese patients. We really can't abandon regional anesthesia in these patients, because that can benefit the most from opioid sparing and improved analgesia. So I think it's important to think, don't get lost just because you're doing a thoracic epidural and it's not working and the ultrasound hasn't really helped you. Think about what else you can use, and think about all the other tools in your toolbox. And you may have to pivot and change course when something isn't working. And as stated in, there was a recent editorial, which I state here, this the mid-transverse process to the flora block. And they found it's a good alternative to the paravertebral block in the obese patient. So there's a number of fascial plane blocks, and I know there's going to be a really great lecture in a couple of weeks about that, and I look forward to tuning into that. So, the MTP block, the rectospinal block, the retrolaminar block. So it's important to know that there's options in the anatomy, and sonal anatomy are not ideal, especially in the obese patient. We had a patient earlier in the year where we were trying to do a thoracic epidural. We were struggling. The ultrasound wasn't helpful, wasn't giving us, we could see midline, but we still weren't able to find our way in. Then we got scanned for the paravertebral space. Because of the morbid obesity, we could not visualize the pleura very clearly, so we really didn't want, and it was a GYN procedure, so we really didn't want to proceed with a paravertebral. So then we changed course and we did bilateral erector spinae catheters. And the patient did very well. So I think it's just important to remember there's options in the obese patient. So just because the first option doesn't work out, don't abandon. Keep trying and think about what else you can do kind of, in your algorithm. So here was a patient that I scanned as for a BMI of 41. So we could see our transverse processes there, the pleura, that hyperechoic area, which would be shimmering in a live view. And the star would be the midpoint between the transverse process of the pleura for that block where you could possibly inject. And it's a novel block, not a lot of literature, but it seems promising. And then here would be where you're injecting under the erector spinae muscle for the ESP block. And I would say I tend to use the ESP the most as far as all these novel fascial plane blocks. And again, it's a very easy, good alternative in the obese patient, especially. So I think it's important to leave this thought here, as it's well demonstrated in the literature that the use of ultrasound results in increased accuracy and success rate with neuraxial procedures in the obese patient. So this is from the Hospice, Society of Hospital Medicine for hospice physicians. And lumbar punctures are different, and the anesthesiologist and neuraxial anesthesia is different. But I found this position statement by the Society of Hospital Medicine interesting. And they state when ultrasound is available with providers trained to use it, ultrasound should be used. Sorry, flip forward. Ultrasound should be used to reduce the number of attempts, especially in the obese patient or patient with difficult to palpate landmarks. So I think it's a question, should it be standard when ultrasound's available for especially neuraxial anesthesia in the obese patient? So I think it's something interesting to think about. So in summary, ultrasound of the spine can be a very useful tool in the obese patients, and it's important to practice in the non-obese patient to improve that pattern recognition. And then you'll be able to very clearly see the patterns, and it'll decrease time to do the scans. The image quality will be less in obese patients, so expect that. But you will be able to identify midline and usually most of the interspaces. It's ultrasound assisted with pre-scanning and marking is of more benefit than a direct guidance in ultrasound and their neuraxial procedures. However, obviously, paravertebral procedures, direct visual guidance is important. And beware of the common pitfalls such as skin movement, skin compression, small movements of the needle to avoid excessive angulation changes. An ultrasound may confer the most benefit of the patient with a BMI over 35. But that's just from a small study, but it just, it was very interesting results. And I always say, scan and then, make sure you're marking, and then you'll have good success. So I just want to say thank you. And here's some pictures from around our campus at Jefferson. And the statue on the right is the Samuel Gross statue from the famous Gross anatomy painting, which was actually hanging in Jefferson for a very long time. So thank you. There's my contact info, and I look forward to the Q&A.
Thank you, Jaime. That was a wonderful presentation. I remember my time in Philadelphia, particularly at Jefferson. Jefferson is a well-known institution. Surely there's a lot of history in Philadelphia. Apart from that, I can see why you have so much obese people. Because of the famous Philly cheeseburger. Anyway, next we're going to have Professor Brendan Carvalho. He's in front of the Stanford Hospital. Wonderful. Okay, Brendan, take it away.
So I guess good morning, good evening, wherever you are. It's a great honor. Thanks, Manoj, for the kind introduction. And I'm going to talk to you specifically about neuraxial ultrasound in the obstetric population. Now, this is where I live and work. This is Stanford University. I work as an obstetric anesthesiologist and also a regional anesthesiologist. I've been here for the past 20 years and spend a lot of my life with an ultrasound in my hand. Now, COVID has obviously changed a lot of medical practice and how we conduct our lives. But interestingly, in the obstetric setting, it's business as usual. A lot of things have carried on, not without much change. And that's why this is important topic to be covered. And I'm glad Manoj included this in the webinar series. Before I begin, just to say I have received honorariums from B. Braun and Ravana. I have some contacts with Accurate device, which I may discuss later or will discuss later, and Flat Medical, a loss resistance syringe device. So as you all know, when we do an epidural or a spinal, it is essentially a blind procedure. We use palpation, but for all intents and purposes, we really don't know what we're going to encounter until we start the procedure. And pre-procedure ultrasound provides invaluable information. We know all of these things that it can bring to us, and including knowing midline, depth, optimal interspace, angles of needle insertion, etc. But does all this information make a difference, and does it make a difference in the obstetric population? So where is the evidence for this? And luckily, there are a number of studies, and the overwhelming number of studies have come from the obstetric setting. So this is a recent, in fact, the most recent meta-analysis. It covered 32 clinical trials, so over 3,400 patients, but 22 of which were in the obstetric setting. So a lot of what we know about how effective neuraxial ultrasound is comes from the obstetric literature. So we know it is extremely useful in estimating depth. And a number of studies show an excellent correlation within a mean difference of 3 millimeters. And as Jaime mentioned, this difference can be increased in obese patients without good technique and without releasing the probe pressure when you actually measure the difference. So the 95% agreement levels can increase by a centimeter. Generally, it's going to underestimate, so it's a safety margin, overestimate, so there's a little bit of a safety margin where you're advancing your TUI needle. So the utility of knowing depth is that you know when you anticipate loss resistance, and maybe avoid false loss resistance. It's particularly important, as Jaime has shown, for obese patients, and knowing what needle to select before you put your needle in, because generally what we do when we don't get loss resistance is we think it's deeper, but very often it's over to one side. The other reason is we're not very good at estimating which interspace we're going for. And this is not our fault. The landmarks we use, the Tuffier's line, is not very good at predicting it. It's only right about 1/3 of the time. And generally, we're 1 or 2 interspaces higher than we think we are. And this is even more exaggerated in parturients because of more adipose tissue that's collected on the iliac crest, and generally leads us to think it's higher than we should be. So ultrasound is very useful in identifying the exact space that we would like to put our needle in. In terms of determining the optimal space, this was actually a very clever study that looked at changes during pregnancy, what happens to the epidural space, and which is the best interspace in terms of ease of insertion based on ultrasound features of longer laminal space, more visible dura, and a more shallow depth. And they noticed that it did change over the trimester, so it gets more difficult the more you progress in pregnancy by virtue of increasing depth specifically. And they found that L23 on average is the best interspace. So if you are trying to find a space that's most likely to get into, it's L23. But this is an image in the bottom left of an MRI study where they were looking at optimal window sizes and the different interspaces. And you can see the lower thoracic and upper lumbar being the largest windows as measured by MRI. So if you were again going to select it, it's that sweet spot of optimal space. But what is critical to appreciate is the scatter plots are all the way up, implying that every patient is different, and the utility of using ultrasound to look at this particular individual patient and which interspace has the biggest acoustic windows is very important. All right, so does it really help you get the epidural then? Well, there is, like I mentioned, a lot of studies, 32 trials, 22 of which are on the obstetric literature. There's actually now 4 meta-analyses that have looked at it. So we have very, very good data on at least insertion. And the technical failure risk, that's not being able to get CSF with a spinal, unable to get loss resistance with an epidural, is halved by using a neuraxial ultrasound compared to palpation. You can decrease your needle punctures by increasing your first pass success, decrease redirects, as well as needle punctures. And by virtue of doing all of this, you can actually save time with the procedure. So while you do use time to scan and see the optimal insertion point, you make that time back with your insertion technique. So optimizing insertion has been very well shown, and numbers needed to treat just in terms of first pass success being estimated to be around 5. But what is less known, and something I want to highlight, is it actually leads to subsequently better labor analgesia. And there's a number of studies showing this. Less likely for blocks to fail, less likely to have to replace your catheter, a decreasing need of supplemental medication for breakthrough pain, and even less pain, not only during labor, but for subsequent intrapartum section. And therefore, it's associated with higher satisfaction. Now, why does this occur? Well, there's a number of proposed mechanisms that we think will mention that you get better accuracy in terms of avoiding loss of resistance if you know what depth you should be encountering loss resistance. And this is particularly helpful in obese parturients that may have false loss resistance before you actually encounter the ligamentum flavum. There is some suggestion you're more likely to be midline, and blocks in the midline should work better because you're getting better spread. We actually did a study to try and prove this. We're unable to show it within our study confines. But probably the most likely explanation is you going into the correct interspace. I mentioned the midline study that we did. So what we actually did in this particular study was, after an epidural had functioned and we were going to remove the epidural, we calculated how far the insertion point was from the midline and then try to correlate it with the amount of pain the patient had and how much local anesthetic they could use in labor. What we didn't really account for is the insertion site where the catheter is coming out doesn't necessarily mean that where the TUI went in. So that may have explained why we didn't find a difference. But in meta-analysis data, they actually don't find differences with symmetry of blocks or adequate dermatomal level using ultrasound compared to palpation. So again, the midline theory is probably valid, but it just hasn't been proven. And the data for optimal insertion probably explains it all. There's a very elegant study where they deliberately put an epidural either in L1-2, so a high placement, or a low placement, L4-5. And what they found is the high placement worked well during first stage of labor, but in second stage of labor, it was too high to be effective for the sacral aspect of pain. Because as you know, as the baby descends, pain goes from a contraction pain, which is more visceral. And as the baby descends down to the sacral canal, you get more of a somatic intense pain. And if you're up in L1-2, it's unlikely you're going to cover those dermatomes adequately enough to take away pain. There was another study that looked at it, didn't really find a difference. It was underpowered. They found a 91 versus 81% S2 block after initiation of block when they were using ultrasound compared to a non-ultrasound guided technique. But this is the leading theory why we get better subsequent functioning analgesia. Now, does it improve safety? Well, there's a number of theoretical reasons why it would. You're identifying the correct interspace. You're unlikely to go high. And like I mentioned, if you're at least 1 or 2 interspaces higher than you think you are, and the spinal cord ends at L1-2, and you think you're at L2-3, but you're actually at L1-2 or T12-L1, you can see how the risk, there is a risk of being able to hit the spinal cord. Equally for neurological risk, there's a good association when you look at traumatic placements of having multiple needle passes, and by reducing a number of needle passes, you should, if you do enough cases and neurological injuries, reduce that. The problem with the safety is it's always a secondary outcome, and the level of evidence has never really been there. So I'll show you the best evidence we have currently for safety. So this is from a recent meta-analysis from Young and colleagues with 22 obstetric studies. And I've bolded the incidence data that they found difference when you're using ultrasound versus palpation. So they showed decreased bloody taps or vascular cannulation, traumatic placement, no difference in paresthesia or neurological sequelae. I wouldn't expect differences in neurological sequelae with such a small number of patients and how rare this would occur. Interestingly, they found a difference in postpartum back pain. And this may be due to less insertions with the needle and more like midline placement that is less painful than more lateral placements that go through more muscle mass. They have not found a difference in dural puncture. Again, it's a rare complication. 1%, you would need several tens of thousands to show a difference. But curiously, they found a difference in postpartum headaches. And again, I'm not sure why this effect was shown. Now, a lot of the studies look at patients with normal anatomy, and it's this sort of anatomies and obesity that really we struggle with a lot more. And I know there's going to be a lot of talks on this, so I don't want to go too much in this area, more than to say that about 4%, estimated 4% of neuraxial blocks turn out to be difficult. And with difficulty, you get increased complications, both inadvertent dural puncture. In fact, it's estimated for every 1 centimeter deeper you go, you increase your accidental dural puncture rate by 19%. So difficult placement and more likely to have complications. So this is where neuraxial ultrasound really becomes extremely beneficial. So the labor studies that have looked at obese parturients and the advantage of using neuraxial ultrasound show the following. So in one study a number of years ago by Grau and colleagues found less insertion attempts and fewer catheter advancements, taking all comers, both obesity and then predicted difficult back spine patients. In 2 separate studies looking at purely BMI, one using a cutoff of 35 and one of 40, found again less time, fewer needle passes, and a trend towards a lower failure rate, so 4% versus 9.3%. So again, showing the utility in the obese obstetric population. Some of these studies were covered by Jaime for cesarean spinal anesthesia with a BMI of 40, again showing the same theme of less punctures, fewer attempts, higher first pass success. You can see the percentages on the graph from the 2 different studies, and shorter spinal time. But what wasn't highlighted, which I think is extremely important, because I lived through the era of using peripheral nerve simulator for regional blocks, which worked great until they didn't work great. And ultrasound has eliminated those difficult cases. And this study showed that for cases that required more than 10 passes, it was 1 versus 17. So you no longer blindly struggle to find a space if you have some help from an ultrasound device. In another interesting study where instead of looking at BMI, and BMI is a global measure of adiposity, and what we care more about is actually distribution. So what they did is they randomized patients based on just poor palpation. So if they couldn't feel good landmarks, they went ahead and got the ultrasound and was randomized to ultrasound or palpation, and they found fewer needle passes with this technique. What is interesting, which highlights the importance of fat distribution, is the BMI in the study was actually similar between both groups. Again, explaining that the BMI is not a very good measure necessarily of difficulty you may encounter with patients. It really depends on where the fat is distributed. When I leave obesity now, I just want to mention two things, and Jaime did touch on it. I think it's extremely important when you approach a obese parturient, and we have super obese parturients in the US, with an ultrasound, appreciate that your image quality is not going to be what you normally get in a non-obese parturient. And so set your expectations walking in there. But one thing is for sure, you will always get two very, very useful pieces of information. And the first one is you will know where midline is. And you know that because you can look at spinous processes. Spinous processes are going to be relatively close to your probe, so you will see the hypoechoic structure, and that, at least if you measure two of them, you have some measure of where the midline is. And then you will get a measure of depth, but you have to be a little clever. The trick I use is I look for transverse processes. They're more likely to be seen in ultrasound, hypoechoic structures, and that generally directs you towards where you would expect the ligamentum flavum to be. And as Jaime showed you nicely, parasagittal view can be very good, and the correlation between parasagittal view and transverse view in terms of depth is very, very close. So you can get a good surrogate for depth and midline, and together with those two, you can significantly help in this setting. All right, so that's what I think about it. So what do the recommendations show? So the National Institute of Clinical Excellence already in 2018, while they admitted there is limited data, still say it appeared safe and may be helpful in achieving correct placement. So they did give an endorsement already in 2008. Since then, we've had a lot more data. And as Jaime highlighted, there is now a Society of Hospital Medicine recommendation showing that they recommend it for both obese and non-obese patients. So you can use this as justification for using neuraxial ultrasound. The SOAP Centers of Excellence, for those of you who are not aware of it, it's an award that the Society for Obstetric, Anaesthesia and Perinatology give to centers around the world. One of the criteria is to have ultrasound available, and specifically highlighted in blue for neuraxial blocks. So it's recognized to be an important skill for an obstetric anesthesiologist. In a recent meta-analysis, which I've already highlighted by Young and colleagues, they went quite far in their statement, and I just want to read it for you. They said the adoption of pre-procedure ultrasound for neuraxial procedures in obstetrics is recommended, and in the view of the authors, should be considered as a standard of care. We can talk a little bit more about this. I don't know if it has reached the level of standard care, but either way, it's something that is slowly tilting towards it. And having lived through the central line placement, where we used to do blind techniques, and the slow changeover to it becoming the standard of care, I think we're following that same path, be it a lot slower. So why is that, and what barriers have held us back on this particular front? So knowledge and expertise are the two aspects, and the good thing to note, and this is a nice study by Grau from a few years ago, is that the learning curve is actually very flat, and it's an extremely easy technique to learn, other than compared to other ultrasound techniques that are taught in POCUS. You can see the solid line already after 10, you're at close to 90% efficiency. So it's a very flat learning curve, whereas the traditional palpation has a much longer learning curve of around 50 to 60 before you get to a proficient level. Now, equipment can always hold you back if you don't have the equipment, but luckily in obstetrics, we all have our ultrasound available. So using it for the baby, we have the same probe and the same ultrasound. We just can wheel it across and do a quick neuraxial ultrasound when we need it. We use it so frequently, we actually have two separate standalone fancy machines that we can use for our POCUS and a neuraxial ultrasound. That's how frequently it's used in our obstetric setting. And then the expertise, and you obviously have to learn this, but it's not a difficult thing to learn. There's very good reviews, very good videos online to be able to learn it. It's something that I even had a colleague learn at the time where he turned a video on when he was struggling with the block. He didn't have the expertise to do it, and he learnt it and did it in front of a patient. Don't know if I would have been too reassured with my physician learning just before doing my block. There might be help along the way, and I did mention a conflict of interest from an honorarium I've received from the manufacturers of Acura, but it's a handheld device that has an image overlay. So it takes the expertise aspect out of it. It image overlays so that not only can you see the depth automatically being shown, but it also has a 3D navigator showing you to move left and right. So it's a very clever device. And it also comes with a locator guard, which you can slide off, indents the skin, so you know exactly to go in the middle. So you can see from these images, the image in B being off to the right, it's a blue line, it's saying it's not quite there. And when you slide it to C, it lights up, it shows you right in the middle, and the depth there is 4.4 centimeters. So a quick device and relatively useful device to use. We've shown that it works pretty well. The difference between the device and the TUI depth was 0.6 centimeters with high first pass success, and accurate along the entire range from 4 to 7 centimeter depth that we were looking at. But this was a non-obese population. It worked as well as a fancier console ultrasound machine, although the console ultrasound was slightly more accurate relative to the TUI, so 0.33 versus 0.61 centimeters, but both equally accurate in determining midline. And this is in laboring patients receiving epidural analgesia. For spinal cesarean, using the same device, they found in the obese population, they were able to, again, same theme, less needle insertions, fewer needle passes, and that difficult spinal, the greater than 10 passes, was significantly reduced. So this is in a BMI of greater than or equal than 30. There were some larger patients. In my opinion, in very large patients, there's nothing better than a high fidelity ultrasound device. You need all the help you can get. So this is probably the mid-range utility. And a last study using the same device for combined spinal epidural in obese patients, again showing the same things we've seen with normal ultrasound devices, with higher first pass success, less redirects, less needle punctures. I'm not sure why they found a lower incidence of paresthesia, perhaps being more midline, and then pretty close, and accuracy similar to what we found with our study. Image overlay is not unique to Acura device, and this is out of a Singapore group that used an image overlay from a standard ultrasound device, and I think this will become standard practice for us when we're doing our techniques where we have image overlays to be able to help us, direct us, and improve our interpretation, also giving automatic depth measurements, which would be very useful to the clinician. Instead of having to go through the measurement routine, you can automatically see the number. Okay, so with all these advantages I've gone through, why are we still, not using it in every single patient? I think there are some barriers I showed you in obstetrics. I don't think they are insurmountable. We have the devices and it's a relatively easy technique to learn. But I do think we're still deficient in data, and not so much efficacy. It clearly works better to insert, speeds up the time, and all the other things that I've shown you. But the thing that will really move the needle is showing if you decrease dural puncture. And I think that's going to take just a lot more cases and clever study designs to show that. The national recommendations are moving in that direction. I don't think they're necessarily strong enough. It's not become a medical legal standard, at least in the US. So there's still a long way to go for this to be a standard technique for all patients. And I do think we need technological improvements to get over the last hump. Now, I'm a big fan of pre-procedure, and all these studies I've been showing you is pre-procedure ultrasound, but what about real-time scanning? And I know Manoj is a fan, and he's super expert at it and described it very early on. A technique that's very useful in the right patients. And this is a study showing in 60 patients, reverse palpation, a nice paramedian in-plane approach, significantly reducing needle passes, improving initial success and shorter time to placement. So I have no doubt this is a technique that's useful in the right patient with the right anatomy. But in the difficult patients, and we'll probably hear more about this, it doesn't necessarily solve all your problems. And this is just a table I've taken out of one of the studies that looks at it, but you can see the needle insertion time is actually longer in the ultrasound group and the procedural difficulty being higher. So it really depends on your patient and your image quality, how useful real-time scanning is. But perhaps in between one is this from the obstetric population. So this is an obese Parturient of greater than 40, and they had had a failed epidural catheter insertion. This is more than 3 attempts by an experienced provider despite pre-procedure ultrasound. So they just had 10 patients as a proof of concept. They took out the ultrasound and did real-time placement and was successful in most patients in 1 to 3 attempts. They were able to see the TUI 6 out of 10 times, which again is a little concerning if you can't really see the TUI needle. It's imperative to be able to see it all the way through, or swapping to a loss resistance technique without visualizing the TUI when you get close to where the target structure that you want to go. Real-time scanning has issues. You can't use gel because of the neurotoxicity concern, and saline just doesn't work as well. You have to be skilled like Manoj. The average provider is just not going to be able to do it. You need a little bit of help either with an automated loss of resistance syringe, or like I mentioned, get into a certain point, see that you're in the midline, you're pretty close to ligaments and flavum, and then just do the loss, but blindly without watching it go through into the loss resistance. I do think it's important to have good needles to improve the echogenicity and visualization. And I think we'll look back when we have better technology, both with 3-4D images and better guidance systems, and think, did we ever really try and do real time, just manually trying to manipulate everything with 2 providers or 3 hands or whatever we were trying to do. So I think it's just a matter of time as technology improves that real-time scanning will become the standard. So what do I think? Well, I'm clearly a fan of neuraxial ultrasound. I hope I've provided at least very good evidence base behind the practice that we can defend. It certainly facilitates insertion. It improves subsequent functioning in the laboring patient and potentially intrapartum section top-ups. And it improves safety, at least in some of the metrics that I've shown you, but not yet in the big ones, the posterior punctuatic or neurological complications, and that's just more patients needed. It is a very easy technique. I don't think there's many barriers. At this point in time, it's not necessarily something you have to do in all patients, but don't take the probe out only for the very difficult patients. You have to feel like you can actually use it and use it regularly to be able to do the difficult patients, the obese patients, the scoliotics, the patients with previous back surgery or deformities. And one area that might be useful in patients is doing it as part of your initial assessment as a screening tool, or when someone who gives you a history of having a difficult block or who's had a failed epidural that you're going to replace. So I thank you for your time. Sorry, I'm not going to stick around for questions and answers, but you're welcome to email me, send me messages, and I'll try and answer whatever I can. So thank you very much.
Thank you, Brandon. That was a wonderful presentation. I really appreciate it, mate. You've been up quite late. Hopefully I'll return the favor one day. Thank you once again, and take care and stay safe. If there are any questions, I'll try and answer them or to redirect them to you later.
Perfect.
Okay, it's a great pleasure again to welcome Dr. Kenneth Sheah. He's going to discuss with us to understanding the pathophysiology of the more complex spine now. Kenneth, take it away.
Thanks, Manoj. Just a tip to everybody else here. When Manoj issues a challenge like that, returning the favor of working through the night, don't take it up, guys. He doesn't sleep. Be careful. All right. This lecture is actually prepared by my esteemed colleague, Dr. Edmund So. And he presented this in the previous ISSPS meeting. So it falls upon my shoulders to present his lecture for him. So there are a few things that we need to understand with a difficult spine. The most common one that we will encounter is going to be the degenerate spine. And then following that, we're going to talk about a case of inflammatory conditions in the spine, such as ankylosing spondylitis. And then we'll cover a little bit about other miscellaneous conditions like epidural lipomatosis and scoliosis as well. So the most common one that we will encounter is going to be the degenerative spine. And in the degenerative spine, basically, there are two things that will affect us when we do paravertebral sonography. The first is extra calcifications, and the second is reduced joint spaces. This would include reduction in the size of the facet joints if we're doing facet joint injections, which then may necessitate us to perform it as perifacetal injections rather than intra-articular per se. And also it will reduce the size of the interlaminar space because of the calcifications. There are a few distributions which we need to be careful about. These include supraspinal ossifications, interspinous ligaments, calcifications, and calcifications in the facet joints. So for example, let's look here at an X-ray of the thoracolumbar junction. Here you have spinous processes, which you can clearly see, and the supraspinous ligaments which traverse the spinous processes demonstrate partial calcification. Now, although we may not see calcification on X-ray, just a word of caution, when you do an ultrasound, don't be surprised if there is actual early calcification as well. And sometimes the ultrasound is actually a bit more sensitive than X-rays, surprisingly, in picking up calcifications. So it's always useful to have these images on a light box next to you as you're going to perform this on a difficult patient. It's better to be forewarned. And if you look here, that calcification in the interspinous space will definitely get in the way of the ultrasound beam and will also interfere with counting of the levels as well. So when you encounter a patient like this where there is supraspinous calcification, how do you count the levels? Look for the transverse processes. That's one useful tip because the echogenic tip of the transverse processes can sometimes be seen and will help you to count. If you lose track of that, you can then turn your probe in a longitudinally, orientate that with respect to the spine, and sweep laterally until you see the trident sign. And once you see the trident sign, that will help you because those the tips of the transverse processes present themselves as the tips of the trident, which Manoj has shown us in lecture 1. Here's a CT scan of supraspinous calcification, and the CT will be more sensitive in picking up calcifications. This patient had a prior vertebral plasty in a vertebral compression fracture. But you can see here calcification along the supraspinous ligament in the upper part of the lumbar spine. and that will make it difficult to assess as well. Supraspinous ossification can also occur in the region of the sacrum. And you can look here if you're doing a sacral epidural, as well as if you can identify the sacral hiatus, that will be good. But the egress of the needle into the epidural space will be difficult, because you can appreciate how narrowed down the central canal within the sacrum is at this level due to the calcifications. The other thing that you also get is narrowing of the interspinous distances. With collapse in disc space, the spaces between the vertebral bodies will reduce, and together with that, the spaces between the spinous processes will also reduce. And when you do an ultrasound scan, that makes it very difficult in terms of identifying, number one, the spinous processes, but number two, the interlaminar spaces, which will also follow suit and be reduced. We see this most often in the context of a degenerative spine at L4, L5, and L5S1 levels. Here again, calcifications and loss of joint space at the interspinous joints itself. And when you look at that corresponding MRI, you see these bright signal areas here. These represent bursal effusions, so interspinous bursal effusions. Unfortunately, on ultrasound, it's very difficult to identify these bursal effusions because they're really deep and blocked somewhat by the interspinous ligaments themselves. The other thing that you can encounter with reduced interspinous spaces is also the presence of these cystic structures. These are synovial cysts arising likely from the facet joints itself, and they arise posteriorly and encroach on the epidural space. So looking at the T1 weighted images on this side, we have an appreciation of the epidural fat slightly higher up at L2, L3 and L3, L4 levels. This is about 5 to 6 millimeters of depth, epidural fat depth in the midline. But once you come down to L4, L5, there's almost no epidural space left. And this is a big cyst sitting and encroaching on that space itself. Interestingly, at L5S1, you do see reappearance of that epidural fat again. And this allows perhaps an interlaminar approach into the epidural space at L5S1. But you could easily imagine a scenario where the facet joint synovial cyst was at L5S1, and that would block your access completely. In this patient, there's also anterior listhesis of L5 relative to S1. You can see a step here, and sometimes that can be related to pars interarticularis fracture or just ligamentous laxity resulting in listhesis. Now, the presence of a listhesis usually doesn't cause very much problems for us when we do ultrasound guided blocks. We can, because we're looking for the spaces, the interlaminar space, for example, and they don't really pose that much of a problem unless you start to hit grade 2 to grade 3 spondylolisthesis. But usually the grade 1s are okay. So this slide is just another 3D CT just to demonstrate the narrowing of the intervertebral disc spaces at L3, L4 and L4, L5 levels with calcifications and osteophytes as well. And so once you have loss of intervertebral disc height, you will have loss of interspinous spaces. Here, another example of calcification in the interspinous spaces themselves. And this you will encounter as your needle traverses in the midline, for example, if you're doing a midline epidural. Once your needle goes beyond the tip of the spinous process, you can sometimes lose track of it. And then if you're depending on the loss of resistance, you start to encounter these areas of calcifications within the interspinous ligaments. And these can actually give you a false feeling, a tactile feeling that you may have either gone through the ligamental flavum, for example, or you are hitting against bone. So if you're at this level, again, look out for these calcifications, because you don't really want to insert your needle at this level and encounter calcifications here. They get in the way of a smooth needle egress into the space. So you'll have to then choose another level which is more suitable. Now, the other thing with degenerative spine, when you have loss of intervertebral disc spaces, is that then a lot of the weight is then transferred to the facet joints. And when the facet joints are subject to wear and tear, the cartilage layers are lost, and then you start to have bone-on-bone contact. And that may sometimes obliterate the joint space. And it's also accompanied by the presence of large osteophytes, which then, number one, distort the image on ultrasound, but number two, distort the needle approach into the facet joint. So here's a cross-sectional image again. Now, not all our patients will have ready CT spine images, which are so pretty. But if you go through your hospital records, you sometimes find CT scans of the thorax performed for these patients, or CT of the abdomen and pelvis, and these will have adequate data for you to reconstruct back into a CT of the lumbar spine. So just go downstairs to your radiology department, and they should be able to generate for you some images of the lumbar spine in 3D. If you've only got the axial images, you can still see that. Just change the windows of your viewing windows to bone windows like this, where all the soft tissue becomes a bit more gray, and you've got more focus on the bones themselves. Now, looking here at the facet joints at this level, for example, you can see how the facet joint anatomy has been distorted. Here, it's relatively preserved, but the right facet joint demonstrates osteophyte formation, and then it's also hypertrophy. There's also less loss of joint space, and also loss of the normal fluid signal within the facet joints themselves. And if you look here, there's a bit of a lip for you to park a small 22 gauge needle into the joint space. But here there's no fish mouth appearance to the facet joint. And with these cases, sometimes you have to admit defeat and perform a periphacetal injection. Facet joint cysts, I've shown you a example previously. They can occur within the spinal canal and result in spinal canal narrowing. They can distort the epidural fat. They can also be seen externally. Usually the externally located facet joint synovial cysts are not of much concern because they don't cause very much problems with the neural structures, and they can be left alone. So that's with degenerative spine. We now talk about scoliosis, and Manoj will show you an example of ultrasound-guided neural axis blocks in a scoliotic patient. There are really, again, two things with scoliotic patients that will distort the anatomy for us. Firstly, you have a lateral curvature of the spine. Depending on how severe the scoliosis is, it can be quite severe, and it can be accompanied by vertebral rotation around the long axis. Here's an X-ray of a scoliotic spine. The convexity is to the right here, and there is a secondary curve convex to the left at the thoracolumbar junction. So if we look here at the thoracolumbar junction, in this patient who is relatively young, there's not much osteophyte formation, not much degenerative change. You can still see the interlaminar spaces quite nicely, the pedicles and the facet joints on the X-ray. And at least these images will help you with your planning. So for example, if you were to perform a central neural axis block on this patient, then you would know to try and angulate your probe accordingly along the axis of the scoliosis. So another one, a patient with a CT scan here. This is in the lower thoracic spine. You're starting to see the appearance of the liver. And you can see how much the ribs sort of get in the way and reduce that space between the transverse process, the ribs, as well as the spinous processes. So on the compressive side of the scoliosis, you're going to have much less space to work with as opposed to the convex side of the scoliotic spine. And this needs to be taken into consideration. The vertebral body is also rotated around the central axis, and this will be another confounding factor as you search for the midline. And in this sort of situation, it's always worthwhile when you're doing your procedural ultrasound to map out the tips of the spinous processes with a skin marker. So at least you know roughly where you are going. Another CT scan showing you how severely the lateral convexity can be in these cases associated with vertebral rotation as well. And in this patient with long-standing scoliosis and combined osteophyte formation around the intervertebral discs, you can imagine that the interspinous spaces are also going to be severely narrowed down. Another condition where we have a lot of dystrophic calcification is in the inflammatory conditions, inflammatory spondyloarthropathies of the spine. These include rheumatic diseases, such as ankylosing spondylitis, reactive arthropathies, psoriatic arthritis, and other spondyloarthropathies as well. The main thing and the uniting factor is that there is dystrophic calcification in all these cases. Now, for ankylosing spondylitis, the main thing that we have to remember is that the intervertebral disc heights are usually preserved. But then the problem then comes is that you have calcifications, ossifications, and anthesophyte formation flowing along the longitudinal ligaments, the anterior, the posterior, and also the interspinous and the supraspinous ligaments. And these new bone formation result sometimes in bone bridging when they're advanced. And again, they can attenuate the ultrasound beam. They can get in the way of labeling of the spinous processes as well. You can appreciate why they call this a bamboo spine now on the CT scan. The disc spaces are obliterated. They're almost calcified completely through, except for this appearance of this bamboo-like appearance of the spine. A lot of bone bridging. In psoriatic arthropathies, you get enhancement with contrast-enhanced MRI of the interspinous and the supraspinous ligaments. Eventually, these can calcify up as well. The other thing that's important is that if you have enhancement here in the interspinous spaces, it's not advisable to pass a needle through it because then the number one, you're not sure if it's infection. And also number two, they can be very painful as you pass a needle through these areas of inflammation. So that's with spondyloarthropathies. The main thing is formation of new bone and calcification of the ligaments. Another condition where you get abnormal calcification in the body is in patients with prior history of injury to particular areas resulting in heterotopic ossification. Firstly, these can appear quite aggressive and may be confused for tumor in some cases, so they will require some degree of workup. But if you look at the CT scan here, This is an example of a heterotopic calcification. It's smooth. There's no interrupted periosteal reaction. There's no large soft tissue component. There's no erosion of the underlying bone. And usually there's a history of trauma from months before or years before. But once again, you can imagine that if you've got an ultrasound probe coming up here, you'll suddenly see this calcification appearing. And then you'll be confounded because it's more superficial than the tip of the spinous process. So this is something that you need to be aware of if you have prior imaging. Another condition, which I warned you guys about when we were talking about the lumbar spine, is that when you assess the lumbar spine, don't ignore the T1 weighted images. Those are really important for evaluation of the degree of epidural fat. Now, the epidural fat is our friend when we're doing lumbar neural axis blocks, and also relevant for epidural injections. In some cases where there is obesity or a history of steroid use, chronic steroid use, these patients can present asymptomatically with epidural lipomatosis. So what's going to happen is that you place the needle in a paramedian parasagittal approach. You think that you're into the epidural space, but when you perform your injection, it doesn't flow around the thecal sac because of the proliferation of fat around the thecal sac itself. So this is the problem of epidural lipomatosis. It retards the flow of the epidural injectate. So how do we appreciate this? Again, look at the T1 weighted image. The T1 weighted image usually has dark signal for the CSF around the spinal cord, but bright signal for fat. So this is the subcutaneous fat that's normal and bright. As you come in, you're looking for that epidural fat layer, which will be our protection when we perform injections. And then if you look at a patient with epidural lipomatosis, that fat layer is thickened. So this is thicker than normal. And sometimes it can encroach on the spinal cord itself. So there's been some work performed about doing 3D computed tomography, CT scans essentially, for difficult thoracic epidural needle placement. And they show that the number of attempts would increase as the interlaminar places were occluded. But you can get CT reconstructions readily available from prior CT scan studies if you have access to the hospital records. And I would advise you to make use of those when you're doing your pre-procedural planning. So in summary, you should be able to access some degree of imaging for your patients from previous studies. Get hold of those if you anticipate a difficult procedure. CT with 3D reconstructions are very good if you require assessment of calcifications, because they demonstrate bony anatomy very well, and they demonstrate calcifications in the ligaments very well. When you perform MRI, they are good for soft tissues, but in our case, the main evaluation is for the epidural space. It gives us a gauge of how much space we have, working space we have when we perform our blocks, and gives us a good overall view of the anatomy. With that, I conclude this presentation.
Thank you, Kenneth, for the wonderful presentation once again. I take this opportunity to thank you thrice for the contribution, and hopefully in the near future, not so near future, we'll do it again in Hong Kong, my friend.
Excellent.
Take care and stay safe. Okay, as I mentioned, just to let the other speakers go away, it's a weekend. So if any of you have any questions, please put them on your chat. Oh, sorry, Rossini, you're here. So can you please, are there any questions for the speakers so far, Jaime and Kenneth?
So we've got some questions here. So we've got some questions for Dr. Baratta about ultrasound guided neuraxial for morbid obesity patients. So we've got a questions from Dr. Sandeep Matha from India. So they're just wondering why you have better sonal images in patients with high BMI than in lower BMI, because I think it's not very much as expected.
It wasn't. That was a unique patient. It was a younger patient, and it was just kind of the distribution of the adipose. I think we got lucky, honestly. In most cases, the larger the BMI, and I've also found, in going with, what as we would expect, the changes as patients get older. The older patients will be more difficult imaging. So I think it was just a younger patient, and that's why I always say, just because they're super morbidly obese, it doesn't mean you're not going to get good information.
Okay, thank you. So we've got another question from the same participant. Any experience on post-bariatric surgery patients, because their subcutaneous fat is reduced and the stabilization of landmark would be more difficult?
So, I mean, that's what's important really with any obese patient, but especially in the bariatric patient, because they're going to have a lot more loose skin. So that's, marking can be difficult. So it may come down to, really anchoring, that area to make sure that you're not getting lost when the skin moves. So it can be more difficult, and that, because of all that skin movement, to kind of lose your place. But it still can be done. And again, it can still give you, valuable information.
Okay, thank you. So another question, I think for all speakers, you can probably answer this one. So how accurate is ultrasound identification of vertebral level compared to the gold standard using X-ray and CT?
Oh, when you look at ultrasonography, it's not 100%. The published data indicates that you can accurately locate a given intervertebral space in about 70 to 80%. This is better than 30% when you look at your landmark base. So there are different reasons why you're not 100% accurate. These are validated with correlative CT imaging. Is that you may have lumbarization or sacralization, because L5S1 is often used as the starting point from where you start your count up. So, and even if you use the 12th rib, which is rarely used, there can be anatomical variation. So I think you can never be 100% correct. So this is my answer to your question.
Okay. Another question from Dr. Joan Carlos Sosa. Again, I think this can be answered by all the speakers. How to identify osteophytes or any other alterations that will warn you to stay away from a certain scan space?
When you do an ultrasound imaging, if you see alteration in the normal anatomical pattern, like for instance, if you're looking for an interspinous view, and I'm not saying that it's a narrowed interspinous, but you're looking for the articular pillars and the transverse processes with the typical the spinal canal producing the cat's head-like appearance, you will find that often osteophytes, if they are related to the articular processes or they are, facet joint related, then sometimes you may see that you can only see half of the posterior complex, or even part of the posterior, the dural sac. Now, this is a telltale sign that there may be osteophytes or something producing acoustic shadows. Now, it could be ossification in the interspinous ligament too, but generally, I find that this is something that appears in the ultrasound image, and whenever you insert a needle where there is the shadow that produces the acoustic shadow, you will often strike bone. So These are not well described, but I think with experience you will find that these are some telltale signs. I don't know if anything more you can add to that, Kenneth?
Yeah, I agree with you, Manoj, completely. These areas of calcification can be very small or can be very big. The big ones, I think, will block your view completely. And if if you look at the images that I showed you, the ones that are relevant to us are the calcifications within the supraspinous and the interspinous ligaments, because those can really get in the way of the acoustic window. Now, when you're doing a real-time ultrasound, you're really looking out for a safe space to inject. So assuming, number one, you don't have any pre-procedural imaging, which is rare in these days within the hospital setting, then as you're looking for that space, you get a sense that, number one, the anatomy is not right, and number two, you can't find the spaces that you're trying to identify, and that's already a warning sign one. And that's why, as Dr. Carvalho said, even with routine cases, you want to at least place an ultrasound probe and build up your database of what normal should look like. And once you have that database of normal in your mind, when you encounter a problem, you get a sense that this is not right. Now, the other thing I wanted to add was that the difficulty of numbering the spinous levels. Spine surgeons have been known sometimes to perform surgery at the wrong level, and wrong level surgery is a big litigious issue, especially in certain jurisdictions. And one of the ideas that has been floated is the use of fiducials, so implantable fiducials. For example, radiology department can insert for you certain markers, even certain clips at certain levels in the thoracic spine, for example. And when you're doing a fluoroscopic injection, you see the marker, and then you know that it's at that level. For ultrasound, I think it may be a good idea to at least develop or have a similar implantable fiducial that you can mark out at the tip of a spinous process, for example, or even the transverse process. This will then allow easier or more reliable repetitive identification of that level. So if you have to go into that space again, at least you have a level identifier, number one. Number two, whenever you infiltrate that particular area with local anesthetic before you insert your spinal needle, for example, that can also, if you get a bit of air into that syringe, that can really distort the ultrasound image as well. And so if you have a bright, shining fiducial implanted within that level, you can go back and identify it with some reliability. So that's an idea for us to consider.
Yeah, that's a good thought, Kenneth. Any other questions, Rossini?
I have a question myself for Dr. Sheah. So just wondering, for the epidural lipomatosis, are we able to visualize them on ultrasound images so that we can predict the efficacy or the limitations of our procedure before we perform it?
It's a good question. Now, if you recall the images that we have, let's take L5S1, for example, because that's a nice, reliable level that we can use. L5S1, luckily, doesn't have very much epidural fat. It's got enough. So you can identify the ligamentum flavum, and then deep to that, if you are able to see down to the cauda equina nerve roots, that's great, because then that tells you that there's nothing attenuating the ultrasound beam. But I find that it's difficult sometimes because it's a narrow space as well. Fat is usually bright on ultrasound in that space. So if you can't identify the cauda equina nerve roots as clearly as you normally would, move your probe to the other side and compare as well. Again, a high index of suspicion is sometimes required. The usual distribution of epidural lipomatosis is somewhere in the thoracic spine and the upper lumbar spine. Those are the usual areas. So the L5-S1 space, as Manoj has said, is usually quite a safe space to enter. But apart from that, I really don't have that much knowledge actually. If you can really identify it, if you're higher up in the thoracic spine.
All right, thank you.
Manoj, any ideas?
No, man. I wouldn't know, because I think if you just see the patient for an intervention without following up the patients previously, it may not be possible to just say that this is a wider epidural space, because the width of the epidural space, I find, is quite variable.
Yes,
even from patient to patient, or from individual to individual. So although there are some normograms with the width of the epidural space, but I don't think this would be possible to say that this patient has epidural lipomatosis. But I would think this. I was just thinking while you were speaking, is that if you place an epidural and your patient had epidural lipomatosis, then maybe it is conceivable that it may affect the efficacy of the block.
Yes, it will.
In some way. Yeah,
that's right. And also the other problem, Rossini, is that you will have loss of resistance anyway, because once you are through the ligamental flavum, the fat doesn't produce very much resistance. So that can be a confounding problem.
Okay. All right. Thank you. We've got another question for Dr. Baratta from Dr. Lee Lin from Melbourne, Australia. Would you consider MTP as an alternative for paravertebral block and ESP in morbid obese patients for mastectomy?
Yeah, so I think you have to always think about your options, because if if your standard is paravertebral, but if you go and scan and you really just can't identify the structures in the morbidly obese patient, it's important to know what other blocks you can do. MTP is a good option. I mean, there's not a ton of literature out there, but it does appear to, be a, novel fascial plane block that shows some good evidence. I tend to probably the one that I'm, in general, usually going to use if I can't see the paravertebral space clearly and, don't want to, don't feel comfortable because it would be risky for complications. I usually go to the erector spinae plane block, but it's really what you're practicing most and what you're most comfortable with of those different types of blocks. So I think, again, it's important to keep all those tools in your toolbox and go through an algorithm if something's not working.
Okay, thank you. We've got all my questions, but I think this can be answered at a later part of our symposium today, because so there's an anonymous attendee that's asking whether you have any tips for imaging patients with post-vertebral surgery, for example, laminectomy. But I believe we have a talk later on by Professor Karmakar that talks about instrumented bags, so I think we can discuss that a bit later.
Yep, we'll talk about some of these aspects after the break.
Yep. So I think that's pretty much most of the questions that were asked.
Okay, I take this opportunity to thank Jaime. It's early in the morning, maybe breakfast time for you. And Kenneth again for joining in. And it's been a great session and for sharing your wisdom and experience. For those of you who logged in, I would like you to have your favorite beverage and get ready for the next session, because it's going to be quite riveting. And I hope you have a clear mind, because it's going to be an exciting session, and I put together something interesting for you. So don't go away. You don't have to ring the bell or punch this or that. Just go have your favorite beverage and come back in 15 minutes time. Okay, we'll join you again in 15 minutes time. Thank you. Hello, welcome back. Right, in the next session, I'm going to discuss with you central neuraxial blocks in difficult patients with difficult back, particularly scoliosis, folks that have had instrumentations of the back, and maybe some of the inflammatory like ankylosing spondylitis. Now that we have a stage set by Kenneth on some of these conditions. I have no conflict of interest whatsoever relating to any of these, my presentation. So what you hear is what I have based on my experience and know-how on this subject. Nevertheless, whenever you see this red star, it's an important take-home message. So do pay attention. And if you take home a couple of these, I guess I've done my job. I have a disclaimer. What I'm going to share with you is mostly related to the lumbar spine. So it relates to performing spinals mostly. This can be related to doing epidurals too in the lumbar region in these difficult patients. But I'm not trying to propagate the information, knowledge that this is useful in the thoracic region. There is no experience. And in scoliotic patients and some of these difficult patients, you may be subjecting your patient to harm if you consider it. So this is my disclaimer. So do not take this as information that you can use it for the thoracic region, although some of it will apply. We discussed during the first webinar that you can perform ultrasound imaging of the lumbar spine, and the preceding speakers have also highlighted in some of these difficult patients, like Jaime showed you in the obese individuals. You can perform a transverse or a paramedian sagittal scan. You can see exquisite images in normal individuals, and even in the obese individuals, you can see these patterns, although they are located at a significantly deeper location. And sometimes they say that in the land of the blind, if you can see a little more than them, then you are the king. So I think this analogy applies, because if you can see what you are oblivious to when you are doing it with a landmark, then your chances of success is much higher. So today, and as Brandon and Jaime have highlighted in their presentation, that most of the knowledge base and the research base is based on pre-interventional scan or a preview scan. You can identify the midline, accurately locate the lumbar interspace. You can measure the depth to the epidural space, detect any abnormalities in the underlying spine, and then also determine the optimal site and trajectory for needle insertion. It is today real-time ultrasound is not as popular, but I guess there are a school of people like me who believe that eventually real-time ultrasound guidance will be required as a skill for every anesthesiologist, because pre-interventional scan may not be useful in all circumstances. So let me pose a few questions to you. What would you do, ladies and gentlemen, if you had a patient like so? Now, this is a patient with a S-shaped scoliotic spine. She presented with CA breast for mastectomy. She had many other comorbidities, and I will come to that in a while. You could also have a patient like so who presents with a fractured hip with multiple comorbidities where general anesthesia may not be desirable, because these are patients who are known to develop restrictive lung disease. They have poor respiratory reserves. They go on to develop cor pulmonale and right heart failure. So much so that they are also often in extremes of age. And besides that, they are often triaged out to most intensive care units in the interest of resources. So you are often left with very little when you want to consider providing them safe anesthesia. And often the choice is to do a spinal anesthetic in most cases and get the most experienced surgeon to do the procedure as quickly as possible. Yes, it's also possible to do many of these peripheral nerve blocks, say for hip surgery and more distal surgery. But then again, local anesthetic toxicity is something you must keep in mind. What would you do if you had a patient like so? These are patients who have had laminectomy or even fusion surgery in the back. These are young individuals who present with instrumented backs. They are often in the adolescent age. They've had idiopathic scoliosis corrected in their teens, and now they are in their 20s and 30s. They've had trauma or they have other type of surgeries, and they present to you. Particularly the Parturient, who has a back like so with we can see an extensive thoracolumbar scar in the midline where the patient has had a Harrington rod placed. She demands an epidural. She demands to have her delivery, a cesarean section under a spinal. What would you do, ladies and gentlemen? This is a patient with scoliosis with posterior spinal fusion with, again, hardware insertion in the thoracolumbar area. You can see here, these are young patients. These are patients with inflammatory spinal disease. As you can see, this 3D reconstruction shows that the inflammatory process have almost shut down the entire highway to the neuraxis, if you may. So these are truly challenging patients. But today, with all the imaging that we have at our disposition, I think it's time that we should all come together and say that we can deliver neuraxial blocks in these patients. But when you look at the literature, yes, it has been described in the literature. You can see here, these are some publications from as early as 1980s describing the use of epidural in Harrington rods patients, spinal surgery patients, fusion for kyphoscoliosis. And there are also literature which says that you can have a success rate of about 90 to 100%. Although it is technically more challenging and more difficult and has a higher incidence of traumatic placement, increased incidence of dural puncture and paresthesia. But the question is, although these techniques have been described, and most of these individuals may be described as experts because they have a little more experience than many of those who have no experience in them, because these are, unfortunately or fortunately, patients who don't present to your door every day. They come once in a while. So you as an anesthesiologist must be prepared to tackle them. If you as a department are unable to tackle them, then I think this is a disfavor to these patients, because they are young, they've had their spines operated or fixed, and now they demand a normal care like most patients. Even this study, a randomized study by Dr. Chin and their colleagues from Toronto, Canada, looked at ultrasound imaging facilitates spinal anesthesia in patients, adult patients with difficult anatomical landmarks. They randomized 120 patients with high body mass index, more than 35, poorly palpable spinous processes, and moderate to severe lumbar scoliosis. And they randomized them to a landmark technique that you would normally do every day and to an ultrasound-guided pre-interventional scan. This is not real-time intervention, as a pre-procedural scan. Not surprisingly, the first attempt success was much higher. The needle attempt were lower. Number of needle passes were less frequent. And therefore, they were able to establish the neuraxial block much faster and in a shorter period of time, as opposed to landmark technique. Although this evidence is available, but it would be fair to say that there are no established techniques to image the difficult spine. There are no established literature describing what happens to the spine in patients that present for surgery who have a difficult spine. It seems a contrast, because a lot of literature is presented on normal individual, normal spines, etc. But these are patients that come to us, fortunately, as I alluded to, rarely or less frequently, but when they come and provide you, hit you like a lightning bolt, because now you have no other choice but to do a spinal. Otherwise, the outcome of this patient may be different, or the outcome may be poor. And a key to success in these patients is truly understanding the pathophysiology of the spine in patients with scoliosis or instrumented backs. Unfortunately, there are very few literature, as I mentioned, but slowly the literature is accumulating. Now, as Kenneth already described to you, when you look at scoliosis, we all know there is a tilting of the vertebra, or there is a rotation in the axial axis of the vertebra. So this produces the defect of scoliosis. Now, this is the same picture that Kenneth put up from Dr. So. You can see that the vertebra is rotated anti-clockwise in this image description. You can see here. So the articular processes to your left is much higher than the articular process, or the costoarticular intervention, or the lamina on your right here. So this produces a rotational defect, and thereby you can see that it produces the curvature of scoliosis. Like in this case, the patient has lumbar scoliosis. And this is a patient that may present to your door where you have to perform a spinal anesthetic. Remember that we talk a lot about the convex and the concave side. Yes, the convexity occurs towards this side. The skin is usually, this is where you see the hump of the patient. And this side is often flatter. There's often crowding of all the bony elements, whether it is the transverse process, the lamina, or the articular process, or the interlaminar spaces. There's much narrowing. And I will come to that later as to how the osseous anatomy or the landmarks that you are familiar with varies on one side or the other, and which side should you be preferring for your intervention. Now, as I mentioned, in this blue book, you have a detailed technique of how you can image the spine in a neuraxial block in a patient with scoliosis. A lot of credit goes to my colleague, Dr. Wing Hong Kwok, who's not with us, working with us today, but he's in another hospital. But I think some of these concepts that we have built together and is some of the, what I'm going to show you is partly his work. So a simple way to look at it is the water phantom, as I described for you, to learning the osseous anatomy of the bony spine in a normal spine. Now you can see here, this is a scoliotic spine that we've put under a water bath. And then we scanned it from the thoracic to the lumbar level. And it was very easy to determine what we often found. Now you can see here that we have a lumbar model and a thoracic model. It's very simple. It's a water bath. You can see there's actually a drill attached to it, but not that the drill is going to, it's just to keep it steady. You can see the thoracic spine is rotated in a clockwise direction, and the lumbar spine is rotated in clockwise direction to your perspective. So you see that the articular process and the transverse process on your left here is much higher than on the right. So this produces an asymmetry in the position of these osseous elements, as well as the position of the spinous process. Now, if this were to be the midline, you can see here the spinous process is actually deflected to your right in this case. As I mentioned, I'm not going to talk to you about the thoracic spine because I don't encourage you to do ultrasound-guided thoracic epidurals in scoliotic patients. It's maybe fair to say that there are very few indications for it. But anyway, my disclaimer is that. So the first thing you need to do, irrespective of what the patient has, if the patient comes with you and has a lumbar scoliosis, you need to first identify where the spinous processes are located, because they are under the skin, and by identifying the spinous processes, you will know which way the spine is tilted or which way the spine is rotated. Will come later on. So first is you palpate for the spinous processes. They may not always be easy, but you can palpate for them. Or if you can't palpate for them, you can look for the spinous processes as we were able to do with the ultrasound, and I showed you the transverse spinous process window. Once you identify the spinous processes, you connect the spinous process together to produce what is called a spinous process line. Now, this is not a line we have developed. I think, in fact, this literature was described by Dr. Suzuki from Japan many, many years ago in the journal of, in one of the orthopedic and spine journals, and I will come to that later. So if you're looking for the spinous process, then this is the sonographic character of the spinous process with the shadow you will see, and then you place a mark relative to that spinous process. So in essence, in a normal spine, you should see a relatively straight spinous process line. Now, this is not always true, and a lot of this was discussed in our first webinar, that the spinous processes are not often lined up in a straight line. There is some variation in the position, but in generally they are quite close to the median plane, if you may. So they are quite close to the median plane. However, when there is scoliosis, as you will see here, that there is a significant deviation from the midline. So you will see that the spinous process line is more crooked, want of a better word. You can see it's more deviated and curved, as you will see here. And if you remember, Dr. Sheah mentioned that you should do the intervention, your scan, relative to the spinous process line, because this is the fundamental, one of the fundamental basis of your being able to obtain a good image in a scoliotic patient, particularly when you're doing spinals in the lumbar region. Once you know the curvature, if you perform the scan in relation to this spinous process line, your image that you will see should be normal, like a normal individual, because now you know you're not performing the scan relative to the median plane, but you're performing the scan relative to the spinous process line. So hope you have understood that. Next is you, as I said, if you do a transverse scan, now we have found where the spinous process lines are and where the spinous process line is. Now place the step 3 is to place the transducer perpendicular to the spinous process line, as I am doing here, just to show you in a cartoon. As the curvature changes, put it at 9 perpendicular to this, and that will reflect either the spinous process window or the interspinous window relative to that spinous process line. Now, this is just to highlight to you what actually happens. You see there's rotation in the vertebra, so you can see this articular processes are higher. So this is the lamina, and the articular process on your left is higher than this. So this is a telltale. So therefore, if you do a preview scan in a patient, and you, as I mentioned in my first talk, if you see asymmetry in the position of the articular process like so, then the patient has an underlying scoliosis. Also, the spinous process you can see here is deflected more to the right here. Okay, so if you were to insert the needle relative to the midline, you can see that you're only going to hit bone. You're not never going to enter the spinous process, the spinal canal, even if you were to insert the needle through the interspinous space. The only way you can advance the needle to the spinal canal through the interspinous space, if you knew what is the degree of rotation of this vertebra relative to the midline. So this is just to show you how you can find out the degree of rotation in the vertebra. Now, if this is a scan right in the midline, as I'm doing here, in the median plane, so this is the median plane, and I perform a scan, and you see that the spinous process is rotated. Okay. In this video, you can see the spinous process is rotated in the other direction. Now, there's an anti-clockwise rotation where the articular processes on your right are much higher than the articular process on the left. So this is an anti-clockwise rotation, and the spinous process is more to the left of the midline in this case. If you did an interspinous scan, you will see the articular pillars are again higher on the side. It was the same patient as before, but you can now see the anterior complex and the spinal canal in the depths of this structure. Now, although the lamina and the spinous processes are deviated to the left, but this is the interspinous window. Now, this is an important window to keep in mind because there is no single intervention that is useful for performing spinals or epidurals. You must use the window that gives you the best visibility of the spinal canal or the epidural space, if you may, if you're doing an epidural. That would be common sense. So that means you must be used to performing real-time ultrasound guidance with the paramedian sagittal approach, as well as the transverse technique, as we discussed in our first webinar. So I will come to that once again, just to highlight it. So now you can see that it is now rotated. But how do we find out what is the degree of rotation? And this is again highlighting to you that if you insert the needle relative to the midline, you're not going to enter the spinal canal. You're going to hit the lateral elements of this vertebra, in this case, the lamina or the articular processes, etc. So the next step in this transverse scan protocol or step is to determine the degree of vertebral rotation. Suzuki and colleagues described a technique of rocking the ultrasound transducer. You rock the transducer until the lamina and the facet joints, which are now at an abnormal position, come to the same level. That means you counteract the asymmetry that you are normally seeing in your preview scan. What I mean by that, I will come to in a moment. So that means if the articular processes were asymmetrical, you take a maneuver of rocking the transducers until you can see them symmetrically in the ultrasound image. So much so that the interspinous view is now normalized. So this is called a normalized view. The amount of rocking that you do in the transducer will tell you what is the degree of rotation. And Suzuki, and this is from their paper, you can see here, he's got a transducer in hand, and this is called an inclinometer. This inclinometer tells you the degree of tilt or the degree of rocking that you do to the transducer till you can see that the lamina or the transverse processes are at the same level. So now he has counteracted the abnormality that was underlying. So this is the degree of rotation, and this was the basis of the paper that they published from the Kyoto University. And you can see here, and they go at length to discuss why this can be very useful, because this is non-invasive, very simple. You can do it at the patient's bedside, and you can get accuracy, which is sometimes even superior to that when you do it with CT scans. So now this is a cartoon to try and demonstrate to you, okay? So now we have normalized. Now that asymmetry that you saw previously is normalized. How do you do that? You just have to rock the transducer. That means you can see here, the transducer is being rocked. That means rocking the transducer is, take for instance, if this is my phone in front of you, if you see the transducer, rocking the transducer is just, you're moving one end of like this end here, I can just rock this left side, or I could rock the right side. So if I rock the transducer so much and I have an inclinometer attached to it, it will tell me this is the degree of rotation that I've achieved. So now you can see this is asymmetrical, and now they have become symmetrical. So that means the transducer has been rocked through a certain angle, and this is the angle at which you must insert the needle. And conceivably, if you insert the needle in this direction with the interspinous view, then you will enter the thecal sac. Easier said than done, but in principle, you can now see that we can see what is the degree, what is the tilt, and what is the rotation in the lumbar vertebra. So the spinal needle should be inserted. So you now know the trajectory at which the needle should be inserted. Now this is the midline here. Here it would be the midline. So you are to the right and it's tilted in this direction. So the needle insertion point would look rather bizarre, and I will show you that. But you must trust that angle and insert it in relation to that. You can also do a sagittal scan. Now, the preceding discussion was with relation to transverse scan, how to identify the tilt in the vertebra and the rotation, and therefore determine the trajectory at which you can insert the needle into the thecal sac. Now, when you do a paramedian sagittal oblique sagittal scan, you often have to do this oblique slight tilt in the transducer to insonate the beam through the wider part of the interlamellar space, so much so that it produces this very typical paramedian sagittal oblique view with the posterior dura, the posterior ligamentum flavum, and the epidural space. Anterior to that, in this acoustic window, you can see the thecal sac with the coda equina and the anterior complex. The anterior complex, when we do spinal sonography in difficult patients, can be quite useful. Although, as Jaime alluded to, in the very obese individual, it can be quite difficult to even insonate the anterior complex. Now, assuming that the anterior complex is visualized because the ultrasound enters the spinal canal and therefore insonates the posterior longitudinal ligament, the anterior dura, then if you see the anterior complex, then there is an opening in the interlamellar space. So that is a telltale sign to you. So if you are an experienced individual, this is all the information you need. You said, okay, at L3-4, I can see a part of the anterior complex. So my chances of success at L3-4 are higher than at, say, L2-3 or L4-5, where you're not able to see the anterior complex. So we can also do a paramedian sagittal scan. And the paramedian sagittal scan is done parallel to the spinous process line. Now, obviously, now that you've determined the degree of tilt in this individual, if you perform the scan relative to this SP line, you will get a normal paramedian sagittal oblique view. But look at the tilt on either side. The tilt, the paramedian sagittal tilt that you have to perform on, say, this on the convex side, if you may. This is where the hump will be, much closer to the skin. You will see that the tilt is much lower than on the concave side, where you can see that the tilt is much higher. You need a larger tilt. So obviously this makes it technically more challenging as opposed to technically much easier in this case. This can be also shown as Dr. Suzuki and them showed. This is a reverse rotation. You can see this is a clockwise rotation. So on the right now, you see there is you have to achieve a lower degree of the sagittal oblique tilt as opposed to on the left side here, and therefore, but when you look at, although there is rotation in the vertebra, the phantom image here is looking absolutely normal. You are seeing the lamina, the interlamellar spaces. So therefore, if you now insert the needle relative to that scan, then you will enter the interlamellar space and the spinal canal. And this is the basis of how you perform real-time interventions in this case. Now, it's needless to say, for the champions who are championing pre-interventional scan, that this would be totally useless if you are to do a pre-interventional scan and then try to do a real-time to do spinal punctures. In these difficult patients, I think it is mandatory, in my opinion. In my center, we do it all the time, real-time, in these difficult patients. Mind you, if you don't do so, then someday you may cause harm to these patients. Again, this is just to illustrate to you that on the concave side, on the side that the articular press is much lower, there's a lot of crowding in the ribs, you will see that the degree of tilt is much larger, and therefore technically more challenging. The distance to the epidural space or the thecal sac is also larger, so you will find it more difficult to perform it. So this is again shown to you here. We are creating this rotation. We are going to do a scan. So Dr. Kwok is tilting the transducer. You can see here the degree of tilt that he has is much shallower, and the needle is being now inserted in plane. And this is basically the basis of real-time spinal in a scoliotic patients when you're using a paramedian sagittal oblique view. This is a scan relative to the spinous process line, as I mentioned before. Again, the degree of tilt you need on the opposite side is much greater, but the needle insertion is again relative to that. So I'm going to let this loop one more time so that you can have a quick look at it. You can see this is now on the side where there is the elements are closer to the skin. You can see that the degree of tilt of the transducer is much less. The distance to the spinal canal is much less. So the overall technique is more simpler. And on the other side, where the elements are much deeper, the ribs are more crowded, or the transverse process and lamina are deeper, your degree of tilt is much larger, and you need to insert the needle at a steeper angle. Now, as I mentioned, you have to perform real-time interventions in these individuals. There is no place in my book for pre-procedural scans in these patients. Firstly, you don't do them often, you don't see them often, and with this twisted anatomy, you have to be careful where your needle is being guided to. So, as I mentioned, this is our approach to performing the epidural access, which we published many, many years ago. In 2009, it's almost 12 years and more from today. But it also describes combined spinal epidurals using this paramedian sagittal oblique view with the patient in the lateral position. As I mentioned, there is some element of thinking carefully about the ergonomics, because if you're a right-handed individual and you place the patient in the right lateral position, then you will be handicapped in some respect, because the needle now will have to be inserted with your left hand. There are some circumstances when you can't do that, or the condition does not allow you to, and you may have to do it in the right lateral position, as I will show you later on during this demonstration. The needle is inserted from the non-dependent side here, and this is the dependent side. And the non-dependent side, because it's ergonomically much simpler, because your transducer is right in front of you and you can see where the needle is entering the skin, as opposed to when you're doing it on the dependent side, and it's kind of difficult ergonomically to see where your needle is being positioned relative to this thick, low-frequency transducer that you have to often use. The needle is inserted. Spinal injections have also been described. It can also be performed in the sitting position, as I showed you in my first webinar. This is just a quick recap. Maybe performing them in the sitting position is also an alternative. So it depends on individual preference, and you can CSF reflux may also be a little bit easier. What you will see here is that the needle here has been inserted in plane. It's in the epidural space. Of course, needless to say, ultrasound resolutions are not so good to see this every day of the week. Occasionally, you may see one patient like this, and this is what I'm presenting to you, but every day you're not going to see this image. Nevertheless, just to highlight to you that the needle has to be inserted through the interlamellar space, but look at the depth at which the dura is located here. It's about 5 centimeters. So the hub of the needle is about 5 centimeters on top of where the needle tip enters the thecal sac. And I think this is a big issue. Not many clinicians in anesthesiology understand this or pay much attention to. Why? Because they don't do these techniques. And when I describe this to many people, they seem to just turn their backs because they don't believe in it. But let me show you. This is a spinal needle that has been introduced from the non-dependent side. And you can see here, this needle has been introduced through an introducer needle. It is a 25 gauge spinal needle with a very high internal resistance to start off with. And if this were the midline and this is your left, this is your right side of the back, You can see I've already spoken for nearly a minute, and you haven't seen the CSF efflux from the, all right, there you go. Yeah, the first drop of CSF. So CSF efflux can be very slow. And mind you, this is a relatively healthy 30, 35-year-old individual. Imagine you had an elderly person with some dehydration, with in the lateral position. These are individuals who are known to have low CSF pressures. CSF pressures in the lumbar region, in the lateral position, can be as low as 0 sometimes, or even 0 to 2 centimeters of water is a normal normograms, normal CSF pressure. Now, if the hub of the needle were 5 centimeters from where the needle tip enters the thecal sac, you don't have any hope to see any CSF emerge from the hub of your spinal needle. So my message to you is that dry taps may be more common than you think it is. So those of you who are interested, I would point you in the direction of this journal, of European journal, where we described our experience with dry taps when performing paramedian sagittal spinal injection and the mechanisms and physiology behind it. We found that about 10% or more of individuals will have dry taps, frankly, dry taps, no CSF efflux. You will have slow CSF efflux in another 14%. So therefore, 1 in every 4 individuals, you're going to see some difficulty if you perform it from the non-dependent side. Now, so we have described this alternative approach, the TIPD technique, which is a transverse, because it's a transverse scan. It's in plane. It's coming from in plane to the transducer or the ultrasound plane, and it's from the dependent side to try and circumvent this issue of low CSF pressure. I showed you this in my first presentation. This is a transverse scan with a slight offset to the contralateral side so that you don't have to insert the needle too far laterally. So this is the point of it. This is about where the midline is located here. And then you insert the 25 gauge spinal needle through the introducer needle. So the introducer needle is used as a surrogate to help you aim for the thecal sac, if you may. Now, this seems far cry from the images that Jaime showed you, but this is some of the benefits of living in Asia. You can see here the needle has been inserted. It's in the erector spinae muscle. Now the spinal needle is inserted through it. Being a 25 gauge needle, you're not going to see it, but you can see here it's now entered the thecal sac in the transverse view. It's on the dependent side. And as Dr. Pon Patra here, you can see she was doing this. You can see there's a good CSF efflux. We have indeed performed a randomized study comparing the two techniques, and hopefully we will publish this data in the near future. There are other techniques which other researchers have described, and I think may have some advantages when you look at performing real-time spinal. This patient is seated. This is not a paramedian sagittal oblique scan. It's a paramedian sagittal scan with a slight twist, as you can see. They have pivoted the medial, the cranial end of the transducer medially. So that at one end of the image, you will see the spinous process, and at the other end, you will see the lamina. This is better visualized in real time. So they found a success rate of 97%. And if you don't have to perform the tilt, then it sometimes adds a degree, it takes out a degree of difficulty of performing the intervention. That's what I'm trying to say. So if you are trying to do real-time intervention, try this out. You may find this suits you better than doing the oblique scan. Although I personally prefer the oblique scan because you get a better view of the interlamellar space. You can also perform real-time through the L5-S1, and a lot of debate has gone into this. And the L5-S1 is a very important location, particularly when it's a difficult back. When you have scoliosis, instrumented back, this may be the only highway to the neuraxial space, or as I often say, this may be the only stairway to heaven to get you out of trouble when you're ducking and diving with these difficult patients. And I will show you that. Now, just to highlight again, this is an article that Dr. Soy and I wrote at the British Journal of Radiology. This is again highlighting what Dr. Sheah mentioned to you, that there's a lot of complementary imaging available in these patients that you should review. And particularly in centers like ours, where we have a PACS system that can be easily accessed through our intranet in the operating room, in your office, in your coffee room. While you're planning this procedure, then you can quickly review their CTs or the MRIs, and with CTs, you can also render their the three-dimensional images, looking at the structures in different planes, and find out which is the best interlaminar or interspinal space for me to choose in this patient to perform the intervention. So it goes a long way in achieving success in planning the neuraxial block, particularly with the technique and the approach you use. So you should start to become familiar with your PAC system and some knowing how to render DICOM data. Somebody asked the question whether you can use third-party software to render some of these images. Yes, there is a free online software available called Osirix, which you can download and render any kind of DICOM data in your comfort of your computer. So now take for instance, I'm going to show you a few images of how you do it in scoliosis. In my next half of my presentation, I will focus only on these difficult patients, particularly in showing you videos how we do these interventions. But as you can see here, this patient has quite significant lumbar scoliosis. And you can see here, the convexity is on this side. We've done the SP line, we've connected it, we've performed some transverse scans. And then we are now, we have determined that the image is best at this side, although it's the convex side, but you can see here, the image I'm getting is the best. Although I know that sometimes the convex side, not so much in the lumbar region, but in the thoracic region, you will find, again, maybe I shouldn't talk about this, in the convex side, where the hump is, applying the transducer without getting an artifact is quite challenging. So much so that you have to apply a lot of gel to circumvent the area of poor contact. In contrast, in the concave area, the skin is much flatter and it's easier to apply the transducer. But as I mentioned, the neuraxial elements or the spinal elements are more crowded. The acoustic windows are much narrower and they are much deeper. And also there are some MRI evidence that the spinal cord is also shifted to the concave side from the convex side. So that means on the convex side, as you are seeing here, the spinal cord or the neural elements are away from the epidural space, if you may. So you can see here under strict asepsis, we don't use any ultrasound gel. We use saline just as a coupling agent. There will be some deterioration in the quality of the image, but you can circumvent that with using gain and time gain compensation, etc., to try and bump up the the slight reduction in the quality of the image. Thereafter, we just do what we have to do. But note, I'm using my left hand. In this patient, I was unable to position the patient in the other side because the patient would not want to do it that way. So you have to respect the patient. And I did it on this way. And you can see here, the spinal is successfully achieved. As you can see, the needle, this is from that same patient. You can see the needle's been inserted. We targeted the L4-5 in this case because this is the L5-S1, and the spinal injection was the spinal tap was successfully achieved, and anesthesia was performed. Again, now you can see here that we are performing the paramedian sagittal scan relative to the SP line here. Look, the transducer is almost looking at the posterior superior iliac, the iliac spine here. So you must trust this, and because that's the image underlying that you will see will be a normal image. So the needle will also have to follow that plane. As you can see here, the needle almost comes from where the posterior superior iliac spine is located. This is where the anatomical midline is. It's way deviated because this is relative to the spine. So follow the spine and maintain the image and do it so. Now, sometimes some folks ask me, do you do it from the convex or the concave side? I really don't pay much attention to this. I would say the side that gives you the best view should be the side from which you should do it. Although there are some differences, and I alluded to some of them. On the convex side, you will see that they are shallower. the articular process will be much closer, or the lamina will be closer. The interlaminar spaces are also wider, and MRI evidence shows that the epidural spaces are wider on this on the convex side here. On the concave side, the contrary happens. They are much deeper. The elements are more crowded. The distance to the neuraxial elements are much deeper, and the skin is much flatter on the concave side. So this can be a plus, but the other elements are actually, others are a hindrance, if you may, for epidurals or spinals. Instrumented backs are another group of patients that often present for orthopedic surgery, for other orthopedics where they've had spinal surgery done before, particularly spinal fusion. Just to show you that this is a 24-year-old, actually he's a volunteer. We got him in who had a posterior spinal fusion. We scanned his back, and you can see here that this is a transverse scan in the midline. You can see the bones, the metal will appear very bright, and there will be reverberation artifacts. You can see multiple reverberation artifacts and acoustic shadow. These are, again, typical signs that you can see with bone. You can also perform a sagittal scan, and I think a sagittal scan is more useful. You can not only see the bone much clearer, you can see there are lots of reverberation artifact. The rod can be very clearly seen hyperechogenic. There's an acoustic shadow. But as you follow this distally, there will come a point when, bingo, there's no more reverberation artifact, and now you are starting to see the normal spinal anatomy. So therefore, you can very accurately determine the lower limit of the hardware, if you may. So, of course, this can be very easily done in an X-ray, but if you just wanted to do it real time, this is how you can do it. You can start to see bone, and then comes a point where there are no more bones. So you can then determine which is the best site for you to perform the intervention, either in the transverse or sagittal window. Today, we have different techniques, as I mentioned. Whichever you are comfortable with and gives you the best view would be my advice to use that. Now, in this case, you can see the L4, L5 interlaminar space, and this was what would be used in this case. The L5S1 has become an important portal to the neuraxis for performing neuraxial blocks in these patients. And we've discussed at length about this in our first webinar. The L5S1 happens to be one of the widest interlaminar spaces. And fortunately, I think God's grace, I often say God is great because he left this L5S1 open for me to perform this spinal in this difficult patient. It's interesting how often you have everything else shut down. You can't see any neuraxial window, but you scan distally, you find the L5S1 is open. Maybe it's good for the patient, and we perform the intervention through the L5S1. So this is just a quick recap. You perform a paramedian sagittal scan. This patient has a scar here, so you can see some artifacts here. But you can see the large flat surface of the sacrum and the lamina of L5. This is also how you count L5, L4, L3, and so on and so forth. So this interlaminar window is the L5S1. And through which we can very easily perform neuraxial intervention. But do remember that this is at the lower end of the spinal canal. The dose requirements of your for your spinal, depending on the level you want to achieve, may have to be adjusted. And you can see in the MRI there's very good correlation. Also, as I mentioned before, that the sacrum is closer to the skin at this level. So it's also because it's directed backwards. So the L5S1 is much closer to the surface of the skin than maybe L3, L4. Okay, so we can also use a transverse scan because in some individual who have instrumentation or hardware, then you might have to have an alternative way of finding the L5S1. This is a transverse sequence from the sacrum all the way up to the L3-4 level here, L3-4 level here. You can see this is a median sacral crest, the sacroiliac joints on the side. As you scan proximally, you will enter the L5S1 gap. So this is the posterior dura, the anterior complex. Look, it's a very wide anterior complex with the lateral pillars, which are the articular processes, and even the facet joints can be seen here with a short transverse process. Then the next will be the L5 spinous process, L4-5 space, L4 spinous process, and L3-4 space, so on and so forth. So then If you have a hardware at this area, then all you need is to just find this window and perform the intervention. And this is what you will see here. You can see the median sacral crest, and just as you slide the transducer cranially, you will see so this is the median sacral crest for you. And as you slide the transducer cephalad, boom, you can see the thecal sac with the anterior complex here. So this is the L5S1 for you. This is a work that we did with our colleagues in Thailand, with the University of Songkhla and Chulalongkorn and Mahidol University. We showed that if you perform a transverse scan, it's superior to palpation, and there's a good correlation with fluoroscopy when you perform the transverse scan. Particularly, outcome was to identify the L4 spinous process, and it's more accurate than palpation method. So you can either use the sagittal or the transverse view, but depending on your patient, sometimes the sagittal view may not be possible because of the hardware. So this is what I have mentioned so far, that although the L5 is the largest interlamellar space in our training programs, or I was never taught to do a spinal knowingly through the L5S1, as I always say. I may have done it many times, but I wouldn't know if the spinal actually went through L5S1. But it being the widest lamellar space is a very useful and has been used in many difficult patients as described in the literature. However, again, we have experienced a lot of dry taps in these cases, and we discussed why this may be the case. And paresthesia is also very frequent, and why not? Because if you look at the coda equina, it is laden, the L5S1 is laden with these, the equina, if you may, the nerve roots. And these are all packed very densely in the L5S1 space. So you will often find that paresthesia. So it is advisable you do not poke around with the needle too much, because you may enter one of the coda equina nerves. So L5S1 here, you can see the sacrum, the fused elements of the other, and I will come to that. And being very close to the skin, it's not a very difficult proposition. So the concluding remarks are that I think if we can perform spinals, epidurals in this patient, it's a step in the right direction. This is an advanced level skill, so it requires a sound understanding of not only the sonoanatomy of the spine, but particularly in these abnormal spinal cases. So pathophysiology of scoliosis should be understood well. You should take small steps. You shouldn't be expecting to be able to do all this in overnight. As you will already understand that there's a wealth of information here, you should take small steps and make small goals for yourself and achieve this over a year and two. We've achieved this over a decade or more. So, but the fact that we are sharing this to you over an hour, it's already shrunk your learning curve. So keep that in mind. Adequate dexterity in performing these interventions is important. It may look very simple to you when you see these videos, but I can bet my bottom dollar you will find it quite challenging as you start this journey. But it's important to start the journey somewhere that you can aspire to achieve. So if you keep at it and keep it simple and stupid at first, and then move on in your skills, then you will definitely achieve greater heights. I have no doubt in that. As a pre-procedural scan, and I showed you that you can use it to detect rotational defects. Now, when we do airway assessment, Mallampati scoring has become a standard of care, by which we judge whether it's difficult difficult airway intubation, and so on and so forth. There's a lot of literature with it. When you plan a spinal, do you look at the back? Now, I didn't ask you, do you look for difficulty? I asked you, do you look at the back? Many a times, you don't even look at the back. You look at it for the first time when the patient is in front of you. So pay some attention at some of these features. I think maybe in the future, when you, as someone was saying, should we be doing pre-procedural scan in almost every patient? I encourage everybody to do pre-procedural scan, because these are the kind of things that you can pick up if you have the knowledge. As Professor Morigal says, if the mind doesn't know, the eye does not see. So if you don't know that asymmetry of the vertebra is a telltale sign of rotation, even if you did the scan, you would not see it. So learn these basic things, and I'm sure you will be able to achieve greater heights. Okay, with this, I'll just end my first part of this presentation. I'm going to now switch gears to show you some videos of patients that I have I've cared for over the years, and I've built a kind of compilation for you all so that you can try and put all these together in that respect. So I suppose I have to share the screen one more time. Okay, so this should not take hopefully too long. So we got half an hour still, so I should be finished by then. Okay, so this is basically to try and put all this into perspective of patients, into clinical care, how we can apply this in our clinical practice. So again, I have no conflict of interest. One last time, I got to tell you again that using complementary imaging in these difficult patients as part of your planning of these procedures is very important. Just the other week, I was one of the consultants referred about a patient presenting for total knee arthroplasty. Patient had one side where they had a very difficult spinal. Patient was a known ankylosing spondylitic patient. My question to my junior colleague was, does the patient have a CT? So they looked around in the PAC system in our medical care database. They found no recent CT. So I said, we are not going to do this patient until we get a CT done. So you could see here that how much importance I pay to evaluating the spines before I touch them. So do pay attention. It can go a long way in helping you to plan your approach. So this is an individual with thoracolumbar scoliosis, and I showed you this picture before. This is the same patient, but I'm going to show you a few more images in this case. So the patient is in the right lateral position, and although I'm a right-handed individual, now I'm forced to use my left hand. But for some reason, the patient would not want to lie on the left side. So although the pathology, the broken leg hip was on the dependent side, as you can see, she was quite used to that, and she did not mind. So this is a preliminary scan. You can see that there is some rotation of the vertebra. It is a clockwise rotation here. You can see this element is much higher, and this would be where the midline is in this case. So we palpated the spines or ultrasound the spinous processes and created this spinous process line, and then performed the sagittal scan relative to this. Remember now, in most elderly individual, because of loss of vertebral height, because of the loss of the intervertebral disc height, there is often a winging of the ilia crest, if you may. It goes quite high, so the space also becomes quite less. This can also hinder with sometimes probe placement in this non-dependent side. As you can see, the chest is probably chest wall is probably somewhere around here. It's a paramedian, it's a sagittal, it's an oblique scan. We're using a CE5-1 low frequency transducer. But you can see here, I can insonate almost everything like a normal spine. If I showed this to you and I didn't show you the preceding pictures, you would think, oh, this is a normal spine. Spinal in this patient, no big deal. You can perform a paramedian spinal. Yes, once you achieve this image, and you are able to take into consideration how to perform a sagittal oblique scan in these patients, then it's a very simple procedure. We use normal saline. No ultrasound gel is used. Forget about the spring-loaded syringe. And you see, we pay a lot of attention to this alcohol hibitine because if this were the same color, then someday you will make a mistake. And such accidents have happened. Was last reported in Australia. So today it is all colored, and I'm sure in most centers it's the same. But the thing is, when you apply a gauze to the saline and you apply it on the back, I often say that that gauze should go to the bin. It should not return to this gallipot here, because it's conceivable that you may translocate some commensal organisms that are in the skin now onto the gallipot and then onto the spinal canal or into the epidural space. So you must develop a protocol in your hospital where if you're going to use saline, then this saline must be used carefully, because simple steps that you may think is innocuous may be adding more risk to the patient. And if you did not use ultrasound, then this would not be an issue. So here we are performing local infiltration. The introducer needle is introduced, and then the 25 gauge spinal needle is used. Now, we often used fine needles. If they are difficult with the spine needle, that's only when we go to pencil point 22 gauge needles. But 22 gauge pencil point needle is not our first choice. We use 25 gauge, and if we find that it's not conceivably possible or difficult, then we use it. You can see here the needle has been advanced in plane into the interlamellar space, and CSF efflux was slow, as you will see here, as anticipated. So we are aware that, now this is after a minute, okay, or so. You can see here there's no CSF efflux. Now, I think if we were not aware of it, you would be poking day and night and maybe make a big hole in the dura, but you would never get CSF in some cases. And I mentioned why this may be the case. So I think it's quite safe to, although I never used to do this procedure, but the more I do these interventions, now I am more willing to perform a gentle aspiration till you get some CSF that you can see, and then I inject the local anesthetic. In fact, in our paper, we also wrote that without CSF efflux, we injected local anesthetic because we could see the needle tip within the thecal sac. And all these patients that we performed in that series had successful spinal anesthesia. So therefore, dry taps may be more common. So now this is another case where there was a failed landmark-based spinal tap, and they didn't know what the underlying anatomy was like. You can see here there is a tilt of the spinous process, and the imaging is not as pitchy as you would normally think. I showed you. But this is a transverse scan we are doing over the sacrum, and you can see the L5-S1 space is still visible. You will see this is the median sacral crest in the transverse view, and then the thecal sac and the anterior complex. So we did a successful spinal injection in these patients. Also, the L5-S1 is insonated in the sagittal view, and you can see that in the L3, 4, and 5, there are no acoustic windows, in fact. It's only the L5-S1 where you can see the neuraxis. Now, this is what I alluded to before. God is great. He's left this space open for us so that the patient can have a spinal through this. But sometimes you may also see, as you go upwards, you can see some open windows. But again, because this was a spinal for a lower extremity surgery, we elected to inject it at the L5-S1. Okay, so this is a lumbar scoliosis. And again, this is the image. You can see there's a rotation in the vertebra now in the anti-clockwise direction. The interlamellar window is, interspinous window is seen here. Although the articular process is high here with the anti-clockwise rotation, you can see the spinal canal. If you had the dexterity of advancing the needle through this interlamellar space, then the transverse in-plane approach would be quite satisfactory in this case. You can also see we've done the sagittal scan. The L5-S1 is once again visible, although the other elements are pretty much not available. This is, again, some mild scoliosis here, you can see. This patient had difficulty with the landmark technique, but once we put the probe in and we perform the scan, you can see the interspinous window is very clearly visible with a very clear posterior dura. So I think this spinal is quite simple. A transverse in-plane dependent, so you can see the dependent needle entering the thecal sac here, and the spinal injection was performed with no difficulty. Ankylosing spondylitis is another problem that you will often see. This is what produces the typical bamboo spine as it described, where the inflammatory process, calcification of the anterior posterior ligaments and the laminar and the paralaminar structures often shuts down your access to the central canal. These are images we rendered of the CT from this patient. You can see here is a typical CT. This is a coronal view. This is a sagittal view. You can the spinal canal, and most of these are ossified. You can see the posterior and the interlaminar areas, and in this posterior view, you can see. We then looked at the sagittal view of the lower part here. You can see, voila, God left this open for us again. So L5S1. So L5S1 can be a very useful site for performing neuraxial blocks in these difficult patients. So don't shy away from this. And you can see here, the 3D CT rendered image, you can see the L5S1 space is indeed open. It's more open on the right than on the left side here. So you can even know that, oh, I need to do the spinal through this way, this side, rather than if the patient were lateral, then this would be the non-dependent side and on the dependent side. So I think these were the images that we acquired in this patient. You can see that the entire paramedian window is closed. You can see nothing through the interlaminar spaces except at the L5S1. If anybody knows why the L5S1 is always open, not that I'm complaining, but if somebody knows a good scientific reason, I would like to know about it, because this is often the stairway to where I want to be. So often it is good for the patient because we can now deliver spinals to these difficult cases with ease. This is just to show you again that in-plane needle insertion is quite simple. You insert it. Remember, paresthesia would be more common, so don't wiggle and jiggle the needle inside. CSF efflux will also be relatively slow, so gentle aspiration can be useful. So this is a patient I remember almost 8-10 years ago. This was maybe not this one, the one after this. This was a case where there was a failed and abandoned spinal. Now, sometimes, as Dr. Sheah mentioned, just because you have the ultrasound in your hand doesn't mean you are a Superman or you are Superwoman or you are the champion here. You must know to be humble. There are times when you have to know when to admit defeat. And these are the words that Kenneth used, and I like it. You must admit defeat as soon as you know that this is not going to be possible. Because like you see here, as the image loops around, you can see this is a paramedian sagittal view in an ankylosing spondylitic patient. I just can't see any viable acoustic window through which I can reach to the neuraxis. Therefore, we admitted failure. We admitted failure not only because the paramedian sagittal, but also the transverse view was not visible. This is a patient with a post-laminectomy history of the lumbar spine. As you can see, this is a paramedian sagittal view, ladies and gentlemen. This is the cranial end, this is the caudal end, the needle is inserted in plane. The only window I can see here is the, I can't tell you which window it is because none of the laminar, the anatomy, spinous anatomy is here. There's a whole lot of ossification in this area that is happens because of myositis and ossification, etc. So the only space we had was to the L5S1. This was before the time we started evaluating CTs and MRIs. So I guess if today I were to see this patient, I would definitely look at the CT more closely before I stick my needle in there. This is another challenging case. I think this was the case I was referring to. This again highlights how alternating imaging modalities can aid in your provision of regional anesthesia in these difficult patients. Although you're able to perform the scan now, you're able to perform the intervention, the information that you can get from CT and MRI and rendering this in the comfort of your office is exceptional. And you will find this go a long way in achieving success in the minimum number of attempts. So it also tells you why the spinal may have been, you may have a failed spinal in this patient. I think this patient was also a case where they were unable to intubate him. So in the last attempt, they had a failed spinal, sorry. They had a failed spinal, so they went on to give him a general anesthetic, and they found that intubation was very difficult in this case. They eventually intubated him with a fiber optic, but it tells you that general anesthesia can also be quite difficult in these challenging cases. So how would you proceed if you had a patient presenting for, say, a procedure in the gluteal area? I think it was a back sore for skin grafting of a sacral wound. And so these patients are bedridden for long periods of time, and they have sacral sores. So we had actually requested a high-resolution CT. This patient had had a previous spine surgery, and having had the data in hand, we looked at it. As you can see here, some of the posterior elements are missing, and you can see some of them in the higher parts. But you can also see that there's a lot of ossification in the area where the spinal canal is now located. There's also a lot of ossification here, obscuring your needle access to the thecal sac. The thecal sac shape has also changed, and you'll be amazed to see what you can see in this bony window here. Actually, you can see that the ossification is extended into the thecal sac. As you can see here, there's big masses of bone ossification, I guess post-operative ossification from a surgery. And this is from callus formation, I suppose. But when you did the coronal scan, you can still see, looking from behind, we're going from the spinous process anteriorly, you can see that the spinal canal is still communicating. In some parts, it's been obscured by these bony catheters. So what is your technique of choice? Given that there was so much ossification in the lumbar region, and there was a very challenging patient with difficult airway, difficult spine, I elected to choose to do a caudal epidural in this case. We use ultrasound with nerve stimulation and successfully performed the epidural with 20 mils of local anesthetic, which provided perfectly good anesthesia for the gluteal and the perineal area and up to the upper lumbar region, to the lower lumbar regions, and was successfully performed. So sometimes you have to tailor your technique at the spur of the moment to try and achieve what you want. And you can see here, this is a patient's spine aseptic precaution. We're using nerve stimulation here too, because I wanted to make sure that the needle is surely in the epidural space. We are looking for anal sphincter contraction. For those of you who have done caudal epidurals with nerve stimulation, you will know this very well. You look for the anal sphincter contraction, you will see that. So just to show you the relevant anatomy, a lot of this will be discussed in our next webinar in 2 weeks' time, the sacral spine. So when you do a transverse scan, this is what you will see, the sacral conua, the posterior surface of the sacrum or the posterior table of the sacrum, and the sacrococcygeal ligament. When you do this represents the sacral conua on your left in the CT, you can see it's quite a wide area. So, and you can very clearly identify them in the ultrasound. You can also do a sagittal scan to identify the posterior and the anterior aspects of it. And the sacral hiatus is, you can see relative to the sacrococcygeal ligament and will appear like so. However, this anatomy may not always be as peachy as it is in this image, but in most cases, you have to do both the imaging to determine where the sacral hiatus is located. The needle is inserted in plane. Now, this is a sagittal view that we are using. So this is the sacrococcygeal ligament. The needle is coming from the caudal aspect. You insert it, pass through the sacrococcygeal ligament into the, just below the sacral hiatus. because the acoustic window in adults, you're not going to see a whole lot much. But I like to show you what I do in children. I think the same approach can be used for greater success in adults. In adults, it can be very challenging because the hiatus first is quite narrow. And sometimes the in-plane, the sagittal view, although can give you a beautiful image, to get the needle into the hiatus can be very challenging. So we use a biplanar approach. And this is what I do whenever I do caudal epidurals in children, and you may consider it. This is a transverse view in an 8 to 10-month-old baby. You can see here, you can see both the sacral conua with the wonderful anatomy. In fact, you can even see the sacral fat with the maybe the filum terminal here. You can see the filum terminale going through, and the acoustic window is larger. But what I would like to highlight to you is that we insert the needle out of plane. When you insert the needle out of plane, you can be exactly in the center between the two conua. Now, while the conua are very wide in this child, now imagine you have an interconual distance, which is maybe a centimeter or even less, that this becomes more important to be able to guide it between the two conua into the hiatus. And once you have gone through the ligament, turn it to the sagittal view, and then you can advance it into the caudal space. This biplanar approach can achieve 100% success every time, all the time. So if you are going to do it, caudal epidural, my advice to you is to do this biplanar approach, where you do it in the transverse view first, insert the needle, turn it around to the sagittal view, and then adjust the amount of needle insertion you have to do. Of course, you can, in children, you can inject some saline to see the expansion of the epidural space, but you would not have the preview of this in adults because it'll be in the acoustic shadow. You can use some Doppler to detect any medley of colors within the epidural space distal to the sacral conua, because in this, what I often describe as the beak of the bird, imagine this is a beak of the bird, you will see some flush of colors if you use color Doppler. Finally, this is the last one. This is going to paravertebral block in a patient with scoliosis. This is an elderly patient with thoracolumbar scoliosis. She had an S-shaped scoliosis. She had multiple comorbidities with SLE, hypertension, deranged renal function. She had ischemic heart disease. And as a consequence, she also developed cor pulmonale from the severe thoracolumbar S-shaped scoliosis that she had. She indeed had right heart failure a couple of times before her admission. And this time she was admitted with the left breast cancer for elective modified radical mastectomy. So this was a surgery that she was going to have for her breast cancer. Echo showed that she was a New York Heart Association 3 with the moderate TR and a pulmonary artery pressure about 55 millimeters of mercury. So that is significant in a patient who is an elderly, about 78 years old. So we decided to perform a multi-level paravertebral with a pectoral plexus block for surgical anesthesia. Now, this pectoral plexus block, we will discuss more during our webinar that is designed specifically for this. So for today, just take it that we are using this to block the pectoral nerves. So this is the patient. You can see she has a severe scoliosis and she presented to us. So first we performed an examination. We were aiming to perform a T2, T4, and a T6 paravertebral injection in this, combined with a pectoral plexus block for the surgical anesthesia. The latter because we have demonstrated that multi-level paravertebral blocks on their own with sedation is inadequate as the sole anesthetic technique. We will discuss more about this in that webinar 8 or 9, I think so, 8, I suppose, at a later date. So please go through the program, and if it interests you, do be there. So we find the SP line, you can see here, and then you perform place a transverse line relative to this, and then you perform a transverse scan relative to this SP line. I mentioned to you the window that you want to achieve. It's either the transverse process view or the articular process view. Now, because this is on the concave side, there's a lot of rib crowding in these spaces. So although I prefer the articular process window, there's a saying that when you are a beggar, you can't be a chooser. So whatever window was available to me in this patient, I was more than happy to use it. So as you will see here, this is the spinous process. This is your lamina. This is your transverse process. And this is the ligament, the internal ligament membrane, internal intercostal membrane, and the parietal pleura. And this is the apex of the paravertebral space, which would be where Dr. Shibata performed his injection. So this is the Shibata window, as I often say. You can see a needle has been inserted in plane and it's been inserted to the apex of the paravertebral space. This is just to show you that you can normalize that view by rocking the transducer. So this is what we did. You can see now, actually the spinous process is right in the middle and the lamina are in the same horizontal level. So aseptic precautions, the needle was inserted from a lateral to medial direction. And this is just to show you a zoomed up view. We performed T2, T4, and T6 in plane, local infiltration, needle insertion with an echogenic needle. This is what you have seen in the ultrasound window. The needle is inserted in plane to the acoustic window. And once the needle tip is there, we inject a bit of saline and expand the space and deposit 6 to 8 mils of local anesthetic of an appropriate surgical concentration to achieve the anesthesia. You can see widening of the paravertebral apex and the intercostal space here. Of course, we can't see spread medially. Patient is then turned supine. We perform a transverse scan, identify the relevant anatomy. The injection is performed between the pectoral muscles and then deep to the pectoral muscle at the level of the thoracoacromial artery. This 2-injection technique is done so that we can block a majority of the neural components that make up the pectoral plexus. So the concluding remarks to you is that although the scoliosis and these other inflammatory spine condition pose a challenge to you, if you have a sound understanding of the pathophysiology and have the appropriate dexterity in performing these ultrasound-guided intervention, then real-time spinals and epidurals are possible in the lumbar region. So with these few words, I hope you found this presentation interesting and hope you will take away some messages home. And if you have any questions, I will be happy to answer them. Thank you for your attention.
Hi, Manoj?
Yes.
I've got a question. You know, with regards to the sacral epidural, the biplane technique is very nice. The issue that I wanted to ask is how far caudal should the entry point of the needle be when you're doing the out-of-plane localizing approach? Because if it comes in too obliquely, then sometimes it bumps up against the bone.
My answer to your question would be is to go as caudal as possible and start your transverse scan. So imagine you are near the coccyx. Okay, you're coming up, and then at a certain point, you will see the two conua will just appear on as two bright dots, right? And that tells you where the caudal end of the hiatus is. In the elderly patient that you are dealing with, there's probably not as wide as in children. So if you go cranially, you will now see the median sacral crest of the sacrum. So my advice is you perform a scan at the coccyx and move it cranially till you start to see the two conua, and then optimize your image there and place the center of the ultrasound probe at the center of where you see the image and place your needle out of plane. Now, it's so simple and stupid because now you are right at the center of the hiatus, and you insert your needle, you will see it immediately inside the epidural space. You then turn your transducer and gently guide your needle into the canal, if you may, because now you're in the blind side of the posterior table. So then you use your fluoroscopy or whatever you use in your, before you inject your steroid, I suppose, then you can do that. I find even in children where the imaging is so good, doing it this way, I find success in the first attempt is achieved every time. Because the issue that one has to understand is that when you do a scan, even if it's a sagittal scan, it's a 1 millimeter plane. So you don't know whether you're on the lateral side of the hiatus or on the inferior side of the hiatus. So whereas if you do the transverse scan, in 3D, you know that this is the center of the hiatus. And once you insert your needle into the caudal space, turn the needle transducer sagittal and search for the needle. And once you see it, you're home. So don't tell anybody this secret, Kenneth. Any more questions?
So we've got two similar questions from two different attendees. One is Dr. Afik Saimi, and the other Dr. Sandeep Mutha from India. They're both wanting to ask about the dosage and volume of drug for SA for patients with kyphoscoliosis because of the possible unpredicted spread and also the risk of patchy block or unilateral blockage. So do you have any experience to share with us?
These are extremely good questions. I think as an academic, I don't have an academic answer for you, put it this way. There are no studies to say this is what you should be doing or what has to be done. I think often it's a case of using common sense. Now, when I do them at the L5-S1 level, and you're using it primarily for, say, hip procedures, etc., then in our, say, Hong Kong Chinese patient with a habitus very similar to most other Asian community, we would not inject more than maybe 2.6 mils of local anesthetic. And this, yes, it produces up to T10, sometimes even higher. I'm happier to handle hypotension than no anesthesia in some of these cases, if you may. So what do you do to overcome unpredictable spread? This is something I haven't got an answer for you. Yes, because of the twist and turn in the spinal canal, your prudence would dictate that you are going to expect some unpredictability in the spread. But when I'm using it for surgical anesthesia, I am prepared for that. And I just use the volume that I mentioned to you. I often tend to use a hyperbaric solution. So hyperbaric bupivacaine is my drug of choice in these cases. And I use about 2.6 mils. Now, one has to remember that as you go down the thecal sac, and we talked about this at length during our webinar one, is that there are some pharmacodynamic issues when you are injecting into the thecal sac at the coda at the L5-S1. Actually, there's a lot of tissue, there's a lot of less fluid in that area. But to say that there are MRI studies where they have segmented fluid and tissue, they don't seem to show a statistical significant difference. But in clinical practice, you will find that there is not as much fluid at the L5S. It's common sense because your thecal sac actually tapers as it gets to the L5S1. Your coda equina is tightly packed within the thecal sac. So that's why you get a lot of paresthesia. And when you perform a spinal, particularly in the lateral position, you may not always get CSF efflux. So these are some pointers for you, but I don't really have a very scientific answer for you. I inject about 2.6 mils and expect that the level would be variable.
Okay, thank you. We've got another question regarding the frequency of the transducer that you use to scan the spine.
So this person was obviously not there during our webinar one. For you, it's 2 to 5 megahertz. We use a low frequency transducer. And because it gives you penetration, and today with our current technology, even these low frequency transducers give you exceptionally good quality of image. And the divergent beam is desirable because it gives you a wider field of view. You can imagine if you use a linear transducer and you go deeper and deeper, your field of view becomes narrower and narrower. So for all neuraxial interventions, low frequency probes are the norm, or is the norm.
Okay, thank you. Then we have a question from Lin, Dr. Pak Pirom from Thailand. He wants to ask, in case we're not familiar with real-time ultrasound spinal block, do you think to use pre-scan to identify insertion point for, I presume he's asking about scoliosis patients. So what if yes, if we use a pre-scan, what would be the insertion point that you recommend to mark on the patient's skin, whether it's on concave or convex side, and also how to determine the needle trajectory?
Right, Lynn, you always ask a difficult question. Anyway, I think that's a very important question. I think the answer to that would be you perform a scan, and the view that gives you the best view of your target, whether you are aiming for L5S1 or L345, should be the window you should use. If you are obviously, you put your markings relative to that. If you're doing a paramedian sagittal view, then you put a paramedian mark. And if you have that information in your mind's eye, then hopefully when you do the intervention, you will perform the intervention relative to that SP line. So joining up that SP line, as you see, I religiously have put marks on all the spinous processes and have joined them up together just to give me that visual that I'm always staying relative to that line. It's very easy to lose focus of where the center is or where the spine is when you put your drape. Once you place your drape and your sterile covers, you lose the focus of where the structures are. And in order to be accurate, drawing it out as I have always told you and taught you, you do it, and you perform the intervention relative to it. Of course, if you are doing patients with scoliosis for spinal interventions, then I suppose you should be trained in doing real-time intervention. Otherwise, you should ask somebody who maybe has the experience in your hospital to do so. If you don't have one and you just do a preview scan, then I would suggest you do at L5S1 level if it is open, and place a marker where it is best seen and insert the needle from there.
Thank you. I don't think we have other questions for now.
Okay, so I think it's been a great few hours, I guess. Thank you, everybody, for joining in from wherever you are in this world. My thanks again to Kenneth. You've been a star mate. Your contribution has been exceptional, and I'm sure it will help many more clinicians around the world, because after the end of this webinar, we will load it up with your consent, of course, to some educational platform where folks can visit and learn these tips and tricks. Again, on the people and the behind the scene who are getting all these things going, thanks to Brian, Ranjit, and the rest of them. Also, thank you, Rossini, for spending your time with us this evening, and hope you also learned something with all of us. We've also learned a lot. Thank you all. Jamie, if Jamie is still around, thanks to Jamie and Brandon for joining in, and adios to you all till I see you in 2 weeks' time. Thank you.
Thank you.
Bye-bye for now.